are starting our program. Once again, colleagues, comrades, there must be only one conversation in the room, comrades. Please. We cannot have too many discussions, comrades, because it will disturb everything. Please. Firstly, comrades, before we start this program, I will humbly request all of us to rise and have a moment of silence for all the Can we have one conversation in the room, comrades, please? Can we have one conversation in the room? Because us talking to each other is going to disturb all of us, more especially here in front. If you have a pen and a paper, just write a note and give it to that person. My name is Anne Leao. I am the General Secretary of Treatment Action Campaign.
Sibui sa sibuang bagaetso ke Aneleyawa ke mokwaledi kakaretso wa Treatment Action Campaign.
I will hand over to the colleague on my right.
Senhor que está a falar, o nome dele chama-se Aneleyawa.
Ke Ndivuo Rambao ke project officer mo Ritshidze project.
É a senhora que acabou de falar, o nome dele é Mbau, ela trabalha nesse projeto, também é uma das líderes.
Those who were unable to join us physically, those who are watching from home, to mention the few, I welcome the Northwest Department of Health. I welcome the World Health Organization. I know that they are watching visually. I welcome PEPFAR, CDC, USID, ORAM, and the colleagues from the media and other comrades from TAC, from NAPWA, from Sanarela, from PWN, from Positive Action Campaign, and many, many, many South Africans who are watching this session online.
Re ka tswelela pele bagaetso ke rata go ka leboga go nna teng ga lona le ba ileng gore bana le rona fa mme bana le rona ka kgokaganyo ya mafaratlhatlha ke leboge gape le go nna teng ka kgolagano ya mafaratlhatlha ba lefapha la pholo le botlhe ba ileng gore e ka tswa ile magata mmogo mo tirong e re nang le yona.
Okay. your own language, we've got comrades who will translate for us.
Ke rata go ka leboga le bangwe ba ileng gore ba mo di districteng tse rona tse pedi le bona ba mo lesegile. Me fela ke rata go ka gatella kgang ya gore le go lolesegeng ba gaetsho mongwe le mongwe go lesegile go ka bua ka leleme la gago.
Okay? So, also, comrades, for the sake of the increasing numbers of COVID-19, we have since decided that our session is not going to be held inside the hall, but we are here on the tent and in 3 districts, and we have visited clinics in those districts. We have interacted with patients, people living with HIV, people living with tuberculosis, key populations, and as many people. So today we are here to present to the people of South Africa, to the world, this report. So, as I have said, is a report of Ritshidze, a quarterly report, which is based on the work and the findings of the clinics, 14 clinics that we are working in here in Northwest, which is in Bujanala. We visited 4 clinics. In Dr. Kenneth Kaunda, 7 clinics. In Ngaka Modiri Molema, 3 clinics. And also the data which is in this report is based on the work that we did in April until May 2021. And this report is based on the data that we collected through observation, as well as interviews with healthcare users, patients, adherence club members, key populations, as well as healthcare providers such as facility managers, adherence club facilitators, and pharmacists. And also, as much as we have this report on a hard copy, but also we have it on our dashboard as Ritshidze, because the work that we do on the ground is collected, and we are using an online system where we are able to analyze all the reports. But also on this report, also there is work that was done by Treatment Action Campaign, by Stop Stockout Project, and Ritshidze, where we did not only focus only in 14 clinics, but we were able also to visit during this era 56 facilities across Northwest in all 4 districts in May 2021. So without waste of time, I am going to hand over to my comrade on my right, Comrade Undivuo, who will start talking to us about the findings and shortage of medicines, and then we will take it from there. I thank you. Over to you, Comrade Ndi.
Thank you, GS. So the first group of issues are on stockouts and shortages of medicines within the facilities. Stockouts and shortages of ARVs, TB medicines, contraceptives, and other medicines cause disruption, confusion, cost, and can detrimentally affect treatment adherence. 23.5% of patients we spoke to reported that they or someone they knew had left the clinic without the medication they needed in the last 3 months. Here are the highest number of patient reports of stockouts or shortages, with as many as 14 reports at Unit 9 CHC and 12 reports at Mahikeng CHC. So the facilities also reported stockouts, and this data is collected through facility managers, and the highest reports were of ARVs and vaccines. In this graph, we are able to see the specific types of medicines shortages reported by patients. There are 3 reports of HIV medicine shortages at Babong Clinic. There are 4 reports of contraceptive shortages at Bafokeng Clinic. There were 10 reports of vaccine shortages at Buitikong Clinic, and there were 4 reports of TB medicine shortages at Montiastrat Clinic. Of the facilities that reported stockouts, 6 clinics gave patients an alternative, 7 gave a short supply, but 2 people were sent home empty-handed, and that is something that should not be happening within our facilities. A further 56 clinics were monitored by a secondary team led by the Treatment Action Campaign, the Stockouts Project, and Ritshidze. The data collection took place over a fortnight in May 2021. Of those 56 sites, 13 were in Bujanala, 6 in Dr. Kenneth Kaunda, 18 in Dr. Ruth Sohomotsi Mupati, and 19 in Ngakamudiri Molema. The data collection effort revealed an extensive stockout crisis that still persists in the province that needs an urgent turnaround strategy. There were 895 reports of different medicines, contraceptives, and vaccines being out of stock in total across the 56 facilities. So the graph you see, this graph, shows the number of reports of stockouts per district. We can see as many as 407 reports of stockouts across 18 sites in Ruth Mohomotsi. This data is extremely concerning, comrades. Moving on, this graph shows the number of stockouts reported at each of the facilities monitored. 57 stockouts reported at Kokwana Clinic, 42 stockouts reported at Mamutla Clinic, 36 stockouts reported at Komeng Clinic, as many as 61 stockouts reported at Ziohe Clinic, and this data shows the extent of the stockout crisis ravaging the Northwest. In recent months, the PLHIV sector has met repeatedly with the provincial government and other stakeholders, including global funders, on key issues around stockouts and shortages of medicine. In particular, the government promised more staff hires to support the supply chain, but nothing has happened so far. In particular, we draw your attention to the lack of pharmacists at the facility levels. In Ritshidze sites, 4 facility managers said that there were not enough pharmacists in their facilities, and 7 facility managers said there were not enough pharmacist assistants. Across the 56 sites further, 43 had neither a pharmacist or a pharmacist assistant. While protocol dictates that professional nurses act in the capacity in that capacity in clinics, in those instances, a cleaner, a pillar box operator, community healthcare workers, and enrolled nurses acted in that capacity in some instances, just to show the extent of the issue in the province. So we also just look at the average stockout duration, like how long it lasted by district. So of the facilities who provided information, most resolved shortages of medicine in less than a month. Out of data for 220 reports, 121 were resolved in a month or so. Worryingly, however, 28 reports involved stockouts of 5 months or more. Furthermore, shockingly, these cases of stockouts of essential medicines lasted over a year, with one lasting over 2 years. So, in this graph, we see the average duration of stockout by medicine type, with ARVs being out of stock on average for 4.3 weeks, TB medicines for 5.4 weeks, and contraception for 10.3 weeks. Worse still, antihistamines being out of stock for an average of 30 weeks, psychiatric agents for 21.7 weeks, and anti-inflammatory therapy for 25.2 weeks. This is very alarming, comrades. In this slide, we see the breakdown of facilities reporting different HIV medicine stockouts. There are 33 clinics facing a shortage of one or more efavirenz products, 14 with ritonavir shortages as well. Here in this slide, we see the breakdown of facilities reporting contraceptive stockouts. There were 19 clinics facing a shortage of Depo, 18 with linogestrel shortages as well. So in this slide, we see the breakdown of facilities reporting different TB medicine stockouts. There were 7 clinics facing shortages of isoniazid. It is critical that people with TB adhere to their medicines. Stockouts like this put that in jeopardy, risking them with becoming resistant to key treatments, and it is critical that the department works to rectify these challenges timelessly. Going forward, as Ritshidze, we are going to bring this information to the attention of the department at district and provincial levels in real time to assist with the rapid correction of these challenges. So we are now going to move into stories. There are stories that have been collected in the communities that we would like to share. It's experiences of community members in using different facilities and their experience of experiencing stockouts and shortages. So we are going to first start with our videos, which were collected within the communities, and then we will hand over to the community members that we have sitting at the event with us today.
Dipilisi ke di tsa go Mahikeng. Ke nile le bothata last year. Ke ntse for 3 months ke sa kry di treatment tag. Mara ke bile ka ikira ka bo December. Ga ke ya ko teng ba ntare ga gona ntho ba ka etsang go se ga dio. Since go ne ke tsogile gore malwetsinyana a ka nna ntseng phosa ke no dipilisi ba re ke nna dipilisi tsa teng ba re ke ya di lebala nna ka gore ke na le bothata wa gore ga ba re tlhalosetse ga ba re fa dipilisi batho ke tsa medication wa HIV positive. So bothata ba bona batho ba ga ba re tlhalosetse ga ba re fa dipilisi ga ba re tlhalosetse nako nngwe ke rathine yana nako nngwe ke rathi le gone o ifiwa fela ga gona sepe se se bulelelwang o ifiwa fela ene gape ntho e nngwe gape gore batho ba ga ba re like ga ke go tsa re ga gona dipilisi ko pharmacy ga gona ntho ba tlo etsang a re tsamaye ro di reka yaanong nna ga ke ba botsa gore ko di reka ka eng ka gore ga ke bereke ke ba botsa gore ko di reka ka eng ka gore ga ke bereke ene ke feletsa ke tsamaile ke sa di kry bothata pila ne nna nka itlhalosa fela yana ka gore ka bo June re thomile bo kry-a bothata bo ko bo June so la ntlha ke ga ba thoma ba re fa yaka re tlwaetse go ba re fa 3 months ke ga ba thoma re fa gore o ka nna comfortable ka gore bokamoso ba gago go itse go bo felela ka gore phela ka tsone dipilisi tse.
Recording in progress.
A se batho ba buang gore o tsena fela ko tleliniking o fiwa fela gona ga gona sepe se se tlhalosetso nakong ke tla ya ka dateng ba re mme o bo ena ga ba bue le rona shapo nte ke re ba botlhe nka se ka re ole o ba botlhe nako nngwe ke na le go ngala ke re ga o tshwara ka tsamaya ke utlwa gore ga ba ntreati shapo ebe ke tswa ke tsamaya ke bona gore nte ke seke ka arabisana le bone ke bona gore ke itsamele.
There was a time when I didn't get my medication. It was, I forgot the date, but I'm definitely sure that it was on November last year, 2020. I also got assaulted by a security guard because telling him that no, that cannot happen to me. I came there at about 2 a.m., but they still saying they can't give me my medication. Yes, the whole November and December without my medication. But it was not for the first time they did that. They once did it, but that time they gave me a prescription letter so that I can fetch it from a Job Shimankana hospital. Okay. So I had to go all the way on foot because I needed the medication by that time. But in November, they didn't give me a prescription to get it there. They only explained that there is no medication right now yet. They didn't give me a solid explanation. I once thought about stopping taking medication because I already give up on life because I don't see the use. I only told myself that not equally in the Kabane health community. We are not very much not equal.
Kinka HIV, I think HIV treatment le diabetic le high blood le cholesterol. O qala ke sebetsa ko clinic ke ile ko clinic ya Grace Mogomo. Ka kry le gore ne ga ba ntshware hantle ka tlogela ka ya kanana locationing yone ile ntshwara hantle le no entse ntshwere hantle gobane ba kgona gore naganela rona batho ba bagolo ha o tlile hoseng ba kgona go go thusa ba go fe dintho ene dintho tsa teng ha di shota kwa ra re wa shota ga shote le ha ka lo gona treatment for kgwedi and then ba go ra re o khutle mo ga ra kgwedi o gongwe gona tsa months a ba rotlo go nka tse dingwe ga ba nke nako e le ko kanana locationeng
and then kodwa iChris Mkhomo asiphatheka kakuhle ngoba nifike kusuku u3 o'clock ndifole line ngaphandle ama-security azivala ngaphandle ungena ngaphakathi xa zibethi half-past 6 ngona basivulela singena phakathi and then xa sifikayo sihlala sifuna ipilisi asiguli sifuna nje treatment ipilisi ngoba ndi-patient yaseChris Mkhomo xa ndifika phaa sifuna ipilisi sifika sihlale silinde toti ngo-8:30 ibe ngona singena ngaphakathi siyofola iline ngaphakathi futhi ipilisi ze-HIV endiselayo neze-high blood dani xa ndiyakhona ke ndiyela gqiba inyanga kaMatshi ndathola ngepilisi because xa ndiyaphaa ngoMatshi ipilisi bathi isitock asikafiki kufuneka ndize kusasa nge-3 xa ndifika kusasa nge-4 ipilisi asikafiki and futhi kufuneka ustatile uqala ilayini emva futhi ndathi neyana uqala ilayini emva nakhona iqala ilayini emva mahala nje futhi nesitock asikafiki xa ndifika futhi ngolosithathu after 3 days ndithola ukuthi iline isikhona futhi ndifole iline ndiyothola ipilisi ndipompa i-BP futhi game 2 abasohoyi eklinikini xa ufike phaa ukuthi ntate nxa uthi uyathetha ubuze into ebuzayo ntate yalayinini noba uthi ufuna ubuza ukuthi nisitoko sikhona na ndifole iline ndiyazi ukuthi ipilisi sikhona kakhulu andiboni into eqhubeka phaa ngoba nangoko ndithetha nje ndinefayile eziyi-3 zilahlekile ezo fayile andinafayile ndithetha nje so this month bendiyile kule nyanga iphelayo nge-3 kule nyanga iphelayo sukubaza kuMeyi xa kuphela uMeyi ithi nxa ziyi-3 kwezikaMeyi sisiya kuJune ndathola i-treatment bandipha bandiphi i-treatment ngaphandle kwefayile anafayile ndathatha ibhuka nami ndayibhalisa ngayo ndithole bandinike 2 months ndiyaqala uthola i-treatment kule nyanga iyi-2 months ndizawuya futhi end of July iChris Mkhomo bengiqala umbona njengathi banditreata kakuhle futhi le nyanga le kodwa bari inyanga kaMatshi ndiyakhalela andinzelanga next yona ngoba le treatment ndifumananga nje ziyafuna ndiyela i-treatment ngoba vele nasebusuku manje ufuna ukuvukela uzofumana i-treatment because uba ndingasuka apha ngo-7 la utshona ilanga ndiselayinini ngo-6 o'clock uyawuthola u-6 ndile ngoku le nto uba ngenxesha umuntu ufuna uyeka uhlale phantsi uvele uyeke hlala ngoba vele nxa uhambe ebusuku ngalo 3 o'clock ndithatha umntana uyandikhapha sihamba siyi-2 nonyanam skini ngo-11 emini ngo-1 ndabe ndifika apha endlini xa uye eklinikini uyazi ukuthi namhlanje idate yam kusasa ingathi uye ekhodo uyofumana ukuthi ungayazi ucinga ulale nix ithatha kakubi ngoba nxa ufika kulaa pressure ndathi ifake ipressure entliziyweni yakho ifake nxa ufika nakulaa BP i-high blood iphezulu yezama-200 because nawe ukwatile manje ufikile mosoko ufike ngo-3 ekuseni ubetho 7 8 9 abakucheki nix uyokungena phi kulaa sisi unika amapilisi uyaphaa ngo-11 naka ufike ebusuku ngo-3 o'clock amasuku akuvalela ngaphandle ukwazi ungena ngaphakathi uyohlala ezitulweni phaa ngaphandle outline noma imvula yana uhleli ngaphandle nazo into ndizondake esakliniki ayisiphathi kakuhle la ndawo ngoba kodwa abantu amasuku alala akukhathaleli noba ungalimala ngapha ngaphandle ingxaki yaseklini Chris Mkhomo nazi ingxaki yamama phelela apho
nna Donald Mwaki ke tsamaya mo tleliniking ya Tlhaba.
We're going to move on to the community stories.
Re tlile go ya go ka lebelela di story tsa community ba gaetsho ne Dumelang bagaetsho, ke tla rata go simolola ka go ikitsise.
My name is Kgosigo Monane
Leina la me ke Kgosigo Monane
from Lomanyane village in Mahikeng.
go tswa ko motseng wa Lomanyane mo Mahikeng.
The stories that I'll be telling you about five of our stories, and I'll try to keep them short.
Kgang e ke batlang go ka e aroganya le lona e ka nna dikganyana di le 4 kapa di le 5 mme fela ke tlile go di tlhalosa ka bokhutshwane.
And also, I identify as a transgender woman of color.
Ke ne ka lemoga jaaka mosadi wa bong bo bongwe.
The first story I'd like to point out, these are experiences that I've had in more healthy.
Kgang e ke batlang go e arologanya le lona ke dingwenyana tsa itemogelo e ke nnileng mo go yona mo lefapheng la pholo.
And these are inadequate health services.
Me ke ditirelo tse di sa jeseng monate.
Okay, let me first start off with the issue here, my transition.
Tlante ke thomolleng ka go le naneela ka bombami.
So, I started my HRTs last year, November. Hormonal replacement therapy, sorry.
Ke simolotse go bona ditirelo tsa pholo ya go ka fetola bombami.
And having to access these HRTs, each and every month I have to travel to Shawelo Clinic in Soweto.
Me gore ke tla ke bona ditirelo tse dintseng jalo gangwe le gape ke tshwanetse go tswa fa ke ye go bona ditirelo ko Soweto ko Shawela.
And it's very strenuous and exhausting, and financially I can't even afford to each and every month, while we have such services here, which I simply don't understand why can't these services be provided here in Mahikeng.
Me ka jalo ge go bona ditirelo tse dintse jalo kwa kgakala jana mme nka nna le tshwanelo go ka bona ditirelo tsofa go tota go le bokete ebile go le matsapa.
Thank you. Yeah, I find that very problematic, and it's just, yeah, it's a big concern. It's a problem here in Mahikeng because we now have to travel all the way to Gauteng in order to receive such health services.
Go tota go utlwisa botlhoko ebile go le boima ka ntlha ya gore re ipona re tshwanetse go ya go batla ditirelo tseo kwa kgakala mme mo Mafikeng fa re na le lefapha la pholo.
Okay, so I'm trying to keep this as short as I can. I'm going to move on to the next step. The next problem, sorry.
Me ke rata fela go rarolla ka bokhutshwane jana mme ke rata go tlodisa kgannye ke fetele kwa kganneng e nngwe.
Thank you. The other issue would be having to receive these services here in Mohai. Now I'm not talking about the HRTs, I'm just talking about general stuff. For example,
Me ka jalo ge go tota go le bokete go ka bona ditirelo tseo fa lapeng.
yeah. For example, I went into, because I live in Lomanyane village, the nearest clinic, Mahikeng Gateway Clinic. So whenever I need such services, I have to go there each and every time.
Me ka jalo ge jaaka ke le moagi wa kwa Lomanyaneng clinic e ke e dirisang e gaufi le nna ke Gateway Clinic e mo Mahikeng.
So this one time I went there to ask for, I believe I had flu by then, and then in addition to the medication and all, I asked for Anusol.
Ke ne ka ya letsatsi lengwe kwa tleliniking eo ke ya go batla thuso.
Okay. And surprisingly, the nurse found it a bit disturbing. Why would I need anusol when I'm a female? What do I need anusol for? So now I had to explain myself. No, actually I'm transgender, and then I need it for my own personal reasons and all that. Now I have to explain what transgender is. I now have to explain what being gay is and everything else. So it was exhausting.
Ka jalo ga ke fitla kwa tleliniking eo ke ne ke batla di anusol ke ne ke tota ke thusiwa ke mo o ne a sa ntshola sentle gonne ka nako eo fa ke ne ke di batla o ne a mpotsa dipotso di le dintsi gore ka gonne ke motho wa mme me ke dira eng ka di anusol ebile a batla gore a tlhalose gore bomba ge go diragala mme ke selo se ileng gore se ile sa se ka sa mo tshwara sentle.
Yes, and I was very baffled by this because now, does this mean that females can't receive anusols now? Why am I being questioned? Which kind of medication do I need? So how I know medication for and all that?
Ke ne ka utlwa botlhoko tota gore batho ba bomme ga bana tshwanelo ya gore a ba ka kgona go bona anusol mo ditleliniking tsa rona.
Yeah, and then the other issue that I had with the system was the issue of lubricants.
Me le kgang e totang e ntlhoba boroko ke kgang ya di lubricants.
I went into the clinic again, and then I asked for lubricants along with my condoms. And the nurse told me, why do I need lubricants whereas the condoms are lubricated already?
Ke ne ka ya nako nngwe gape ke ya go batla di lubricants le di condom. Me mo ki a batla go nkutlwisa botlhoko kapa go nkgoba ka mafoko a batla go mpotsa gore e le gore ke dirisa ke tlhoka eng ka di condom.
And now again I had to explain why I need lubricants. No, you know, when you're gay or transgender or whatever, you need lubricants for 1, 2, 3, 4, 5. Now I had to explain to her, and in explaining to her, hey, now people were being called, come and listen to this. This is something new. Some didn't even know what lubricants were.
Ya no go le jalo ke ne ke tshwanetse gape go itlhalosa jaaka ke motho wa bong bo borileng gore di dirisetsang me fela jalo ga go ntse go le fao ke le ka go mo tlhalosetsa ke ne ka gamaretsiwa fela ke gore o na bitsa bangwe gore batle go utlwa gore kgang e re tshwereng ke efe.
And going back to my sexuality, at most times I feel like I get away with the fact that I actually look like a female, like a cis heterosexual woman. So I get away with that.
Fa re lebelela bomba mi
these people, when I say these people, I mean the nurses and everywhere else I go. If I disclose to them who and what I am, it's going to be something else now. I'm going to be discriminated against. I'm going to be, there's going to be discrimination, and it's just going to be problematic.
Sengwe se se totang se nkutlwisa botlhoko ke gore ke na le monagano le maikutlo a gore kana fa nka be ka tlhalosetsa baoki gore nna bomba me boeme jang ke motho wa boleng bo bo rileng ke tlile go feleletsa ke ke sa tseiwe sentle ke sa tseiwe jaaka motho seriti sa botho ba ka se gatakiwa ka maoto.
You'd often wonder, hore, if I'm thinking of this, how will it be towards somebody who identifies as a gay man? Obviously, they'll be discriminated against. So now I hide at the fact that I can get away with it and I actually look like a cis heterosexual woman, like I said. And receive these services, you first have to go through security, you register and all that. Now my problem lies within the gender marker in my identity document. I always have to explain myself, hore, you don't look like the male that you say you are in this paper. So it's problematic as well.
Jaanong sengwe gape se e leng tlhoba boroko ke gore gongwe le gape fa ke ya tleliniking fa o tsena mo gating o tshwanetse go bona security o leke go ka tlatsa gore wena o itshupe gore o mang. Jaanong bothata ba me ke gore ga ke kgone go tlhaloganya gore ga ke tshwanetse gore ke tlatse ya ka mongwe le mongwe foo fa ke tlo go maka mo makeng wa gore ke rre dipotso tse ke tshwanetseng go tsona e tota e le dingwe tse di santseng pila.
So it's always a constant struggle. You not only have to fight for your health, you also have to fight for your journey along the way. You have to explain yourself, who are you, what are you, blah, blah, blah. And it's exhausting, especially when having to explain yourself, go back to healthcare workers.
Go tota go utlwisa botlhoko ebile go kgaba marapo gore gongwe le gape fa o tshwanetse go ya go bona ditirelo o tshwanetse go boga mo tseleng o tsamang mo yone.
Yes. And then this other story, this is the final story, sorry. The last story that I'm going to talk about. It's actually a bit lengthy, so I'm sorry.
Jaanong se ke tlileng go le naya sona se ke sona sa bofelo mme lo tla nkinela matsogo metsing gonne ekete se bolele nyana.
So this one time I went into the same clinic, the Gateway Clinic, and when we got there, it was under renovations.
Nako nngwe re ne ra ya kwa go yona tleliniki e ntse ke bua ka yona ya Gateway mme ga ke gopola sentle ka nako eo e ne e santsene e renovatiwa e ne sentse e ka leka go bankanya go.
And that being said, we were told to go to the Denville Clinic instead.
Jaanong re ne ra laelwa gore re ye ko Denville Clinic.
However, the person that was telling us to go there was very rude. Especially bagolo ba ne re na le bone le bao.
Mme ka jalo motho o nne a rare re tle re ya go bona ditirelo kwa teng o ne a sa bui sentle le rona ba leng fao ebile go le bagolo.
So it's actually a distance from Gateway Clinic to the Denville Clinic.
Jaanong go mo kaonyana go ya ko bagaetso.
Eventually we got there.
Re na ra fitlha gona.
On arrival, I noticed that a lot of people, it was around 9:30.
Ka nako eo ke ne ka lemoga gore batho ba ne ba le bantsi ka gonne le ka nna ka boura ya borobong.
And usually, go Gateway, usually people are assisted at around 7:30 or so. So very much earlier than that. So to me, I was surprised by the fact that people are still outside the yard. Basically, why are people still outside?
Jaanong ka nako eo fa re fitlha foo ke ne go na le pharologano e nngwe nne ke ya e bona magare ga Denville Clinic le Gateway gonne se nne se mmakatsa ke gore go le gantsi ke a itse gore ga re le ko Gateway Clinic. Batho molola go thusa batho ka nna ka bong. Mme kwa fa re fitlha ka ona nako ya bo 9, batho ba ne sentse ba le bantsi mme ba bang ba eme kwa ntle.
And when I arrived, I learned that the nurses there refused to offer services to the patients because they did not have facial masks.
Jaanong ke ne ka lemoga gore selo se ne se etsa gore balwetse ba seke ba thusiwa e ne ile gore bangwe ba ne ba se apara di-mask.
So these were older people, and then they couldn't, never sa kgone go ipuella and all that. So now I took it upon myself to stand up and address the issue.
Ka jalo ge selongwe se nne ka sa se lemogile ke gore batho ba ne ba le kwa bontsi ba bona e nne le bagolo bangwe e le batho ba ba senang molomo ba ba sekeng ba ipuelela mme nna ka tsaya dikgato tsa gore tla ntekeleke go ka rarolola matsapa.
So I had an argument with the lady. I believe her name, the nurse, I believe her name was Grace Motlhabane. I had an argument with her regarding these masks.
Jaanong ke ne ra re fosana mafoko le mooki mongwe kwa teng.
My thing was, now in the new normal that we live in the world that we live in now, each and everyone is expected to have a facial mask. Whether we're dropping, wherever you go, you're supposed to have your mask on. So why now is not having a mask an issue? Because when you woke up from wherever you came from with you, why can't you use that mask?
Ka jalo ya ka re itse ba gaetso gore mo matsatsing ana re a itse gore mongwe le mongwe o tshwanetse gore a bana le mask kwa gongwe le gongwe go yang teng.
Oh, sorry. And her reasoning was very lame, actually, and she was very rude, and I was rude back to her. I even asked for her names. She gave me her names gladly, so Grace. So we had an argument there and there about that. And then after everything, after we fought and everything, but we didn't fight physically, it was just a verbal argument. After everything, after that, finally, they were actually waiting for a man to bring these masks. These surgical masks, basically.
Ka jalo morago ga ngangisano ya rona go ne go tlhalosa gore go ne go emetse gore mongwe a tla tlise di-mask.
And as soon as he did, that was when people started working. But ebile I khatla ka the fact that na ha ke tlo bereka government e tshwantseng provide mask. Ha ke sena mask ha ke bereke.
Ka jalo ge ke ge ile gona ba tla simololang go thusa mme a totobatsa kgang ya gore ga ba nkitla ba be ba dira bona ba puso e sa ba fa di-mask.
So besides these stories that I just told you about, there's a lot more, especially with regards to our sexuality and all that. But I'd like to stop here and thank you for listening.
Thank you, comrades. So, before I go further, I must take this opportunity, colleagues, those who are in the room and those who are watching virtually, one, to acknowledge the presence of the provincial leadership of the PLHIV sector in Northwest, the provincial chairperson of the PLHIV sector in Northwest, Comrade Neo Muwepi is here, as well as Comrade Temba Khadebe have also joined us. Two, I'm sure many people in the room and those who are watching online are asking themselves why we are not showing the faces of other people who were giving testimonies. 2 reasons. They gave consent to us to say they are scared to show their faces because they might be victimized in their clinics. 3, we are presenting these recommendations to the Northwest Department of Health and the National Department of Health as partners who are working with the department, but also as the clients of the department. So I am going to read them. We are no longer talking about demands now because we're sitting together around the table, we present recommendations. The first recommendation, based on what Undivuo has presented around stockouts and medical supply, and also our dearest comrade who just spoke. So our recommendations reads as follows. The Department of Health should develop a provincial strategy to address the continued and ongoing stockout and shortages of medicines and other medical tools and supplies. 2, this plan must address the following: the impact of human resource shortages, poor management, and infrastructure on the ability of the facility to order and store supplies, and increasing the number of pharmacy staff. 3, there must be effective and immediate communication of stockouts between the national and provincial departments of health and to clinicians and patients. The other recommendation, efforts should be taken to minimize the impact of global supply chain disruption. The Department of Health and partners should monitor global demand and horizon scan for impending issues to improve international forecasting. Also increase use of buffer stocks, alternative supplies, and other measures where supplies of medicines are particularly uncertain. The Department of Health should share with civil society public supply performance metrics, e.g. pharmaceutical companies and CCMDD suppliers, and SVS performance metrics. The Provincial Department of Health should establish an emergency response team or standard operating procedures to manage crisis situations. We call on them to include clinic committee members, all people living with HIV sector organizations, as well as other civil society organizations. The Department of Health should prioritize pharmacist training in SVS and other supply chain systems. Pharmacist assistance contract were discontinued at the end of March 2021. We call on the Department of Health to reinstate them, fully recognizing that they are the first to notice when stock is running out. This would also help relieve professional nurses of their additional roles and free them up for their primary task. So those were these are the recommendations that we have around shortages of medicines and medical stock out. Now we will focus on issues that are related to staffing and waiting time of the patients. I am going to hand over to my comrade, Simpiu.
Thank you, GS. The second group of issues are on staffing and waiting times. Ritshidze data shows that both patients and facility managers agree that there are shortages at clinics. In Bujanala district, according to 343 patient responses, only 32% of patients said there was always enough staff to meet patient needs. This varies across districts. 12% in Bujanala, 23% in Ngaka Mudiri Mulema, and 77% in Dr. Kenneth Kaunda. Managers at facilities agreed with 100% of facilities that were interviewed that there was not enough clinical and non-clinical staff at the facility. The most commonly reported understaffed cadres by facility managers were professional nurses, enrolled nurse assistants, data capturers, and cleaners. Here on the slide, we can see which facilities reported understaffing in which cadres. For instance, in Unit 9 CHC, they reported a litany of shortages, including not enough doctors, not enough professional nurses, enrolled nurse assistants, pharmacists and pharmacist assistants, linkage officers, data capturers, and adherence club facilitators. This slide talks about long waiting times reported by patients. At clinics like Potchefstroom Clinic, Grace Mokgomo CHC, and Park Street Clinic, the waiting time was less than 3 hours. Patients at 8 clinics reported an average waiting time of 5 hours or more. Patients at 7 clinics reported average times of 6 hours or more. And patients at 4 clinics reported average waiting times of 7 hours or more. Department plus district support partners should go and focus on the 8 sites with waiting times of over 5 hours. Try and find out what the problem is and fix it. We have the clinic names on the dashboard and can provide all that information. We also found examples of clinics where waiting times are far shorter, under 3 hours, as mentioned earlier. What are these clinics doing better? Go to them and learn from them. Take the lessons back to the clinics with the longest waiting times. What are they doing right that can be replicated? It is possible to improve waiting times. It is within reach to do something about it. 68% of patients thought waiting times were long, but this does vary greatly across districts. For example, in Dr. Kenneth Kaunda, only 39% of patients think waiting times are long, but there are very high percentage of patients reporting long waiting times in Ngaka Mudiri Mulema and Bujanala, although we monitor fewer facilities in these districts. Back in May 2019, we were very happy about the new National Department of Health circular. However, 2 years later, through our monitoring, we see not much has changed. No non-24-hour sites reported opening at 5 a.m. The most common reason given for facilities being unable to extend their hours is shortages of staff. We will now proceed to the recorded community stories.
Nna Donald Mwaki. Ke tsamaya mo tleliniking ya Thabane. Kore lo o ile ko tleliniking ko ema line tse di telele selege. Kore a ke tsena kwa ke tsogile fa gore ke tsogile ka bo 4. Ko bo ke ra service ka bo 11 mantsibo motsharo ya lunch. Le teng ga ba fitla ya lunch o se thusiwe o tshwantse ba emele ba ye lunch. Ke service re sa kere. O bo tswa fa le ka bo 4 mantsibo. Nako engwe ba go busa ba go rare o tla ka usana. Treatment o ne re ke rapile maro ke ra morago a sebaka yo. Service ya teng le di nurse tsa teng ai. Ya tena ka gore sontse nako engwe ke na le go tlogela ke itlela gae ke tlogela ke re ke le line engwe tele go tsena ka moteng ba go rare ba ya teng so nako engwe wa itlogela o itlela gae. nako nngwe o feel gore wa give up mo treatmenteng or o ema line nngwe telele sela. Ke tsa di-ARV ke lebetse maina teng ya re ke na le sebabo ma 10 years ntse ke tsa di-ARV emela ba bula ka 80 go safe go re ema kwa ntle kwane go feta batho ba bantsi pele ke le ga safe kwa ntle.
My name is Mahikeng Sofni Tsengiwe. I get my medication from Khabane Community Health Center. I'm taking medication for epilepsy, high blood pressure. I'm HIV positive, and for depression also. I go there at about 2 a.m. in the morning, but I end up finishing up my medication collection at about 12 p.m. midday. Usually the facility is on every time, 24 hours, but from 5 o'clock until 6 o'clock the next day, they are only attending for emergency. By that time you went in to collect medication, they won't attend to you. It's just a long waiting time, and the service there is very pure, to tell the truth.
Dumelang. Ke Zibongile no Jilo buang. Ke tlhaga mo Lemanyaneng. Na nka bua fela ka taba gore re na le bothata mo ditleliniking tsa rona, especially rona basha. O fitlhela o le mo treatmenteng. Okay, tlakilana. Ka 2015 ke ne ke ile go testa ko Stopo clinic. Then sister na nthusa o na na le keng student nurse. Itse ba etsa go kry di results e be nna gore ba shoutana le nna gore why this the results it's ke be ke ba ra ke ha ke itse e ba mpha treatment re fella fo. Yo ke mo lebetse tlheng ish ke simolotse go tsena mo clinic go tsamaya clinic ka 2015.
I started to visit the clinic in 2015.
And then ke nna le bothata ba motho o ne a nthusa ka so se ne ke setse ko clinic.
I had a problem with someone who I had a problem with the nurse that was assisting me at the facility, at the clinic.
Ke testile ene le bolwetsi plus pregnancy at the same time.
I tested and I was sick and I was even pregnant by that time.
How the results status did
I could not respond to her because by that time I was not well, and I was a little scared.
Ke tsamaile kgwedi e one ko Stropo Clinic.
I visited 1 month at Slopo Clinic.
Ka tsaya remove date ya ke latelang ke ya Staten Clinic.
I took my transfer to Staten Clinic,
Mme ke ga ntse go tshwana fela.
but the treatment was the same.
Ko Staten Clinic bothata ba bone ke staff attitude.
The problem with Staten Clinic is the way the nurses are treating us.
Ama ba re treat-a according the way o tla bo ngwa apere ka teng or yang. O tla bo o le mo line-eng o sa bone go tsena phakela ka 7.
The way they are treating us, I don't understand. Is it that the way maybe we are dressing? Because in most cases you will be there as early as you can in the facility.
How do you see aloka 7 o gate? I'm in a 11 o'clock. O sa bone go ema go gate ka 7.
While you are waiting in the queue as early as you can, but when you are supposed to get into the facility, the security guard will tell you that you'll be assisted around 11 o'clock.
How fetela go pele o ya go pompeng ke na le bothata nna ha ke tsena ka site-eng ya gore ke pompe ke busiwa gabedi or gararo BP e le go godimo.
In most cases, when I visit the clinic, when I am going to the site of getting my BP, I will always be returned twice.
Lebaka e se gore e tla be e ipatlile go nna go godimo re dula sebaka kwa ntle go sena ditilo go sena meriti mo re dutseng teng.
The reason why I'm doing this, it is that because I will be exhausted since we are waiting in long queues with no chairs outside.
Ha ke fetsa go pompa le ba tla beng ke na le bone re fetela ka for di consulting room tsa rona.
After having BPs with those that I will be with, we will be going to the consulting rooms.
Ha re tsena mo di consulting room ra tshaba la go bua ba na le gore botsa a pilisi go tsa sentle ha e go lwatse re tshaba gore e ntse isa sedidi ira ka gore na kwa buang le wena ana ka yona wa mmona gore o na le attitude ha go botse ya ka yo le gore o patient mo ge.
When we are consulting, we are even scared of responding to their questions because you feel like you are not going to be treated well because the way that the nurse will be communicating with you is not well.
Mo godimo ga mo ha morar e ke siame wa di bon gore e o di paketela fela mo aba go ra re tsamaya.
If you explain that medication without any explanation that when and how are you taking those medications?
Se botlhoko ka gore re tla be re kopana le ba bang
Sometimes meet people who will be having some other medication, then they will be asking you what kind of medication are you using or what are you taking this medication for, and you will never be able to explain to the particular person because you are not informed.
se ke se buang ka taba medication bathong ke gore go na le ha ke itse gore go na le batho ba ba tsang di medication go na le testing e tseneng ha te fast lane lone re fa bothata o tla be o kry-a medication ya gago let's say botlolo e white kgwedi then 2 months how boa o kra botolo e blue ha ba go bolele and le di-color tsa dipilisi tseo ga di tshwane re nna le mathata go ntsa lo ipotsa a ke defaultile ore ba re ke ile ko godimo ore ba re go iragalang go ha ba re bolelle ha ba re fatlhose sepe.
So we have problems as patients who are taking chronic medicines, because often when you go to the clinic this month, they'll give you your medication, the package is blue, and even the pills inside are a different color, and next month they'll give you a different color, which is confusing because now you don't know if it's still the same medication.
And problem e nngwe gape nna ka ko ke tsamayang teng la ba re tshotse madi ga o kry di-results tsa gago.
My other problem that I have, that in the clinic that I'm attending, even if they've taken blood, I never get results.
And mo godimo ga ba go tsaya madi fela ga ba go bolele gore ka eng o utlwa go tela ke data go ya go tsaya madi o isa letsogo fela ga o itse gore a o donata madi ore ke data go ya go tsaya madi ga te tla o tsaya madi re isa letsogo ela rona ka re ga teng a ke re ba re ke mmereko a bone so re tshwere bothata rona ba bangwe bo bo serious.
So there's also a serious problem that I'm encountering in the clinic that I'm attending. They often withdraw blood from me. They just tell you that it's your date to withdraw blood, but they never really tell me what is the blood for. I don't even know if maybe I'm donating blood.
And se sengwe gape go starteng clinic re na le bothata ba nako mo manneseng a rona re sa itse ke ra re bereke mo di-governmenteng gore na re contract e ba e saenileng go tile gate ba tsena ka 9 nese e tla be e tsena ka 9 ka 10 ya teng le sa bone go dula hatshe gao mara a tswile go gagage go le lata.
Another problem in starting clinic, there's a serious problem of the nurses. Maybe it's because we are not nurses, we don't know what is happening. Is it possible that nurses are supposed to start working at 9 and at 10 o'clock they are going for tea?
And se se botlhoko gore ga ba teng ba botlhe ga re itse gore ba tlhakanela tea beke kokoro go iragala ba botlhe teng ba tsamaya botlhe and ga ba re laele ba shoota botlhe.
And now another problem is that when they do go for the tea, they all leave all together. So we don't know what is happening in the tea room. Are they really supposed to be living together?
Babu, after 1 hour, marona re tlhole re utlwa go teng mo departmenteng tea time is 30 minutes, but ya bone go ba budi 1 hour. Kwa after 1 hour yo go thusa patient tse 5. After patient tse 5 tseo ba ye lunching.
And then they will come back after 1 hour of their tea break, and then they will assist about 5 patients, and after that they will tell you that is their time for lunch, and they will leave for lunch.
Ha ba bua fo ba goga maoto ya no re chaisa le bona 5 o'clock re chaisa le bona.
And then when they come back from lunch, then they start not working. They are just dragging their feet, and we end up leaving with them at 5 o'clock.
Le taba ya di-file re na le bothata ka di-file tsa rona ko tleliniking tlheng o tla bo o kwadisitse o bo ema bo go tsengwa 7 mo pele ga gago go te file ya gago ga e bonwe mare o e tlogetse mo tleliniking gate ga e bonwe ba tsenya ba ba ko morago ga gago ba go hete ba ye ko pele.
There's also a problem of files that get missing in the clinic. We often told that they can't find your file, and other people will be passing people that came after you because they can't find your file whilst you left the file in the clinic.
La o ka kopa re ke kopa re tlheng kwalle mo page-ing le tla sala le batla file ka le tla kwala information yo mo fileng nna ke tsamayeng ka re ga ke bone gotle ba re o dula mo go itlhela re kra file ya gago ga ba ka ke ba go thusa.
Even if you can ask and beg them, can you at least write for me in the page so that I can continue to the consultation room? They will tell you, no, you are going to wait here until we find your file, and they will not help you.
So ke bothata bo ntse ke nna ke bo tshwere bo bokete ene ke sampane ke tlo go tsamaela lo ka bone e ka re ka thusiwa ke lebogile.
Those are the problems that I experience in the clinic, and it's very difficult for me, so I wish that we can get help. Thank you.
Thank you, comrades. Before I can put recommendations on this item, I also want to take this opportunity to acknowledge the presence of May Grace Tsele, who is a host manager in Northwest, who has joined us virtually, and also Ume Puleng, who is an acting chief director of clinical services in Northwest, who has joined us, and also Ume Judika Molemane from the Northwest Department of Health, Provincial Department of Health. They have joined us virtually. So, here are our recommendations. One, we are recommending that the Department of Health must release the Provincial Human Resource Plan by end of July 2021, including comprehensive list of current vacancies and also fill all vacancies outlined in 2021. Two, enforce the National Department of Health circular to open all facilities from 5 a.m. to 7 p.m. on Monday to Friday and 8 a.m. to 4 p.m. on Saturdays. Three, undertake an audit into gaps in staffing, including where staff shortages are a barrier to extending opening hours, in order to develop a turnaround strategy by end of September 2021 to prioritize staffing needs for the next financial year. We will move now to the next issue, which is around collection of ARV treatment. Over to you, Honorable Ndivuo.
Thank you, GS. So now we're going to go into the next issue, which is ART collection. We are pleased to see an increase in the number of people living with HIV who are reporting 3-month supply of ARVs. However, 13.8% of people living with HIV still reported less than 2 months supply. While at times there could be a clinical need for someone to get a shorter supply, often we see multiple reports, for instance, 16 reports at both Bapong and Buitikong Clinic, pointing to a stock issue. 63% of people living with HIV interviewed through Ritshidze received less than 3 months of refills, compared to only 21% of people living with HIV supported by PEPFAR in other countries receiving less than 3 months. Between July to September 2020, of people living with HIV supported by PEPFAR in other countries, 20% of adult men and 19% of adult women received 6 months of ART refills, yet only 0 Ritshidze respondents reported receiving 6 months supply. Compared to other PEPFAR-supported countries, South Africa and the Northwest is lagging far behind in the rollout of multi-month dispensing. So now when we look at the issue of 12-month scripts, 58.3% of facility managers reported giving stable patients 12-month scripts, meaning those people living with HIV are able to reduce the number of trips to the clinic with only an annual trip to the clinic to see a clinician when required. It also allows for longer refills. We urge all clinics to give stable people living with HIV 12-month scripts going forward, as outlined in the Government Gazette in 2020. Okay, so now we're just going to look at satisfaction with internal pickup points. Repeat prescription strategies, including internal and external pickup points and adherence clubs, should be much simpler and quicker systems to collect ARVs than waiting in long clinic queues. Most of the people living with HIV who we interviewed used either an internal pickup point, so 43.5% of respondents used an internal pickup point, or there are those who collected at the facility through the standard medicine dispensing, and this was at 51% of respondents. Out of the 121 people living with HIV interviewed, 99.2% thought that internal pickup points made ARV collection quicker. While we spoke to fewer people living with HIV using external pickup points due to the fact that Ritshidze monitoring takes place at the facility, out of the 14 people living with HIV interviewed, 100% thought that external pickup points made ARV collection quicker. The majority of people living with HIV were either satisfied or very satisfied with both internal and external pickup points. Given the high satisfaction rates, it is important to ensure that as many stable people living with HIV as possible are enrolled in a repeat prescription strategy. Also, given that 58.8% of people living with HIV wanted to collect ARVs closer to home, we should be decanting more people living with HIV to external pickup points closer to home. Now, let's look at adherence clubs. So a key takeaway with adherence clubs seems that people are satisfied with the clubs. This is good evidence that we need to support for more adherence clubs. However, many clubs have stopped during COVID-19. Of those not in clubs, 69.4% of people living with HIV were not aware of adherence clubs, also pointing to the closure of clubs in COVID-19. We should be thinking of innovative solutions to ensure people living with HIV safety from COVID-19 infection, while also ensuring access to peer support and treatment literacy information. For instance, we can start introducing or enrolling smaller clubs or outside meetings where there is confidential space. We're going to move on to community stories.
Dumelang batsadi, ke le dumedisa mo mabitsong a mararo lebitso la ntate la morwalla moya o galellang. Amen. O itse ke botlhoko gore e be nna gore ke bua gore ke fitlhiwe sefatlhego, but ha ke na choice because nna ko tleliniking e ke tsamayang ko go yone ke re ke botlhoko gore ha ke eme yana. By the way, I'm HIV positive. Ke na le 11 years ke phela ka mogare, and I'm proud to be HIV positive because I'm living a positive life.
It's hurting for me to speak today in front of you, but also requesting to be anonymous as a person living with HIV for the past 18 years, 11 years.
Why ke re ke botlhoko ke gore ko tleliniking e ke tsamayang ko go yone mo Tlhabeng clinic ba nkitse.
The reason why I'm saying that it's painful for me is because at the clinic where I'm attending, which is Tlhabeng clinic, they know me.
Mara le gale go siame, to cut a long story short, ke tlo go bua fela se ileng gore nna I have experienced ko tleliniking eo since I was diagnosed in 2010.
Just to cut the long story short, I'll then tell you what are my experiences since I've been attending the clinic since 2010.
Ke diagnosed ka September, if I'm not mistaken.
I was diagnosed in September, if I'm not mistaken.
And then ka tsamaya di session.
Then I attended sessions.
Ka gore CD4 count ya ka was very, very low.
Because my CD4 count was very, very low by then.
And then ka initiatiwa mo arting.
Then I was initiated on art.
And then nako eo ne ke kra treatment sentle ke nako ne go santse go nowa J4.
By that time I had received my treatment properly. By that time we're still taking 4 pills.
Di kgwedi tseo di a tsamaya September, October, November, December sengwe le sengwe ke a se simolla go change.
Time went by for about 4 months up to December.
Ke a
And
le
then
gore-
things changed.
ke ga e le gore yaanong ga ke sa ke ne ke santsane ke fiwa tribus
By then, I was given tribus.
and then be go change ke simolola yaanong ke fiwa troiser
Then I was changed to a trouser.
yaanong bothata ba ka ke gore ga o botsa mannese gore ba gaetsho kana yaanong ga o le patient e leng gore tota ya itlhaloganya o tshwanetse o botse dipotso.
So the problem arise when now I'm asking as a patient who understand myself, like you have to ask question.
A ke re dipilisi tse mo godimo yana di na le dinomoro either di starta ka B something jalo jalo yaanong ga o ba botsa gore tota yaanong ga lo nna dipilisi tse di ntseng yana a gone go siame ba tla go araba gore o se ka tshwenyega they are the same.
So now the problem is this medication are different, like they've got different numbers, even the barcodes are different. Some are starting with like B something. Now when you are starting to ask, but this medication is different, is it okay? Am I supposed to be taking this medication? They just tell you this medication is fine, just continue taking them.
yaanong se se botlhoko ke gore a ke re wena o lwalang ke wena o ikutlwang ga o se no nwa pilisi ye nngwe eo gore e reacta yang mo mmeleng wa gago motho a ba gore a re go siame o ipotsa dipotso yaanong gore ga go te go siame kana go raya gore ba re bola ka bomo mose.
So now the problem arises when you are changed the medication and you start feeling some bad reaction in your body, but when you ask and the nurse just tells you that just continue taking the medication, it's fine, then you start thinking as if they just wanting you to get sick intentionally.
yaanong se sengwe ke ise ke gore ga go ntse go ya ke tswile mo go tseo tsa gore tla bo fiwa botlolo e ka mo se o fiwang go na le nako nngwe e leng gore ke ne ka fiwa 7 tablets ene ke tshwantsane gore ke e sherele wa rre be ke ipotsa gore ga o fiwa 7 tablets be go o e sherele wa rre to my knowledge a ke re treatment is not supposed to be shared.
Now the problem arises at some point, as much as I get confused as I'm given different bottles, at some point then I was given only 7 tablets. And in that 7 tablet, I had to share with my brother. But then I was so puzzled because in my knowledge, I know that I'm not supposed to be sharing the medication.
Still ga o ba botsa mannese ba tla go bolelela gore dipilisi ga diyo tlhoba boroko ke ye dipilisi ga diyo mare a ke re mo go bone mannese ao le bo charge mo ditleliniking tsa rona re itse bangwe amongst their family who are affected ke bone bolwetse bo.
Now the problem is that when you ask why you are given only short supply of treatment, then you will be told that there is no medication in the clinic. But the issue is that as people using the facility, we know that there are nurses and in the facility that they have their families who are affected also, who are taking the same medication.
Bone di tsa bone tsa di family rona re filwe 7 tablets ka rona ba fetisiwa ba go kreiya dibotolo tse tharo tsa 3 months kana so wa bona gore we are not treated equally. Why is that?
So as much as they tell us that there is no medication in the clinic, but there are family members who are also taking the same medication, somehow receiving 3-month supply. And this is a problem. That's where we realize that
leng gore ke tsaya madi ka yone tota ka gore re dira mmereko wa rona Simangele, why o tshwantsane re botse mmereko wa rona? Be ke itidimalela.
So when I was asked why is the needle that they are using to withdraw blood from me is different from the one that I normally use, I was told that Simangele, we are doing our job. Why are you often questioning us? Then I just had to keep quiet.
Tidimalo ya me ile a tsala lefufa ka gore ke fufagela mmele wa me, mmele o ke wa me, ke setse ke na le di-tattoo tsa mahala, so ya tleliniki tattoo yona ke tlhole ke e batla.
So my keeping quiet in that process has resulted in me growing anger because the injection that I'm using resulted in my arm having scars, and I do not want more scars in my body.
Ke be ke fetsa go tsaya madi, I was told to come after a period of 3 days ke tlo go collect the results.
After they withdrew blood, they told me to come back after 3 days so that I can get my results.
Ha ke kopa di results,
When I asked for the results,
ga ba go bolelle sepe, ba tla be ba sheba dipampiri hela kore le phapharapharapha gore o bonela or no ba ita ba re ba ira mmereko be ba re no tla next time di results tsa gago ise ditle. Till this date ha ke se ke kry di results tsa ka tsa March ebile jara ya hela.
so since I withdrew blood around March and they told me to come back after 3 days, I went there. The nurse just kept on checking in the papers and said to me, your results are not here, you'll get your results next time when you come back. And since March to date, I've never received my results.
Kore ke tlo go ke nagana gore ke tlo go e repapa ka gore hang ka ntse ke tlotla tse dingwe re tlo go dula fa for a long day. Man nurse go di clinicing ha ba tlhola ba ntse ba re tsamaya wa gore reporta eng bone kana gore ba re tsosa. So it's high time tshwantsane re me ka dinao re re enough is enough, because
so there is this attitude from nurses in the clinic that often when you go to the clinic and you want to complain about something, they tell you that you can go and report where you want to report. So I'll end this by saying that as communities, stand up because it's our right.
And last year on the 16th of August, I gave birth to a beautiful baby boy. At the present juncture, is he negative or positive? But deep down in my heart, na ke itse gore positive ka re not treatment essence. Why ke sa fiwe di results tsa ngwana gore ke itse gore ke eme kae?
Another problem is that I gave birth to a very beautiful child, but then they not give child to say if the child is positive or negative.
And I gave birth to this boy. Hospital, hospital.
I gave birth to my baby boy at Bupilong Hospital.
Until this date, I say ke create the results. Se sengwe gape ke gore basadi ba bang ba ke tsetseng le bone ka lone letsatsi leo ba kgonne go create di birth certificate ko sepetlele nna or ka gore ke ba di akitse batsadi be go te ke home affairs. Why is that?
And also in the hospital, the mothers who were there with me giving birth on the same date, they also received their child's birth certificate from the hospital. But myself, I don't know if I'm unlucky, but I was I'm speaking like this because us as communities, as patients who are doctors.
Akere due to COVID-19, ha ngwana a le ko sepetlele a admitile wena motsadi ha o sena problem wa discharge. Ha o sena o discharge wa go gae o tshwantsa no check ngwana telephonically so, but when you do so, especially ka nako ya shift ya bosigo, di nurse tsa bosigo le tla intshwarela batsadi ba makgakga.
So now, especially in the time of COVID, as a mother, after delivering the child, if you as a mother don't have any medical problem, you get discharged, but then you leave the child behind. So you are required to keep on calling the hospital to check on the child. But now the problem is that the nurses that are working in the evening, they are very rude.
How phone? I can't remember so fe ngwana lina ba mo bitsa ka baby smile. Ne ke kopa go checka baby smile ka nako e leng gore no ntse mo checka ha o le ka yone ko sepetlele ba go bolela gore o checka ngwana thata man ko ena o tla irang go rush. Why is that? A o tla dula ko ga yo phutulugile o utlwile so seo.
So what the nurses will normally say to you when you are calling, requesting to check how is your child doing, you will be told that you are often checking on the child. That's the reason that you are overdoing it. That will even result in your child dying.
Ke tla ya no mo ditleliniking ke a tswale a re sken ra sheba mannese hela ka boruti jwa bone nya bone ba makgagene le bone ba ikitse ditlinara le tsone ko ditleliniking cleaners ke kopa Ritshidze le TAC I think le tlo go re thusa cleaners ko ditleliniking ba makgaga ko tleliniking ya rona ya Motlhabeng gona le mmegate me mastock unfortunately bile re thusagetse o tsamaile o ile pensioning me o ke ene nako ngwe bila tlhakanyang le di nurse tlhogo mo line ke a bona tleliniki ele ke a gagwe a ba tla ka sekgoa se se rotten ke a bona re rona a ra rutega so please le di cleaners go di tleliniking tshwantsane di shebiwe gore no ba itse gore re batho ke a leboga salute.
So in the clinic, it's not only the nurses that are rude to us, even the mere cleaners that are working in the clinic are the ones that are rude and also causing a lot of confusion in the clinic. Thank you.
Eu também a minha irmã estava no hospital.
I'm standing here on the behalf of my sister who was admitted.
Agora, como estava no hospital, a doença que ele levou no hospital, ela ficou melhor, mas depois foi bem no hospital, não foi com a perna inchada.
My sister, when she went to the hospital, when she was admitted in Bupilong Provincial Hospital, she was not feeling well, but when she was discharged, she was healed by the time she came home. But when she came home, one leg was swollen, but she didn't go with a swollen leg.
A perna encheu, cheguei lá no hospital, me chamaram para ir buscar, encontro a perna está inchada, está aqui, está melhor.
And the nurses called me so that I can go and collect her, that she's been discharged. But when I went to collect her, the leg was swollen, and she didn't go to the hospital with a swollen leg, like I said.
Agora, encontrei a minha irmã, está amarrado na cama, com o braço.
Was tied up with the bed, one arm. She was tied with a rope.
Daí também eu, como não falo a língua, nem perguntei se o porquê assim. A pessoa veio bem, agora a perna está inchada, encontrei, está amarrado, porque eu só recebi a minha cesta, levei em casa.
Because I don't speak the language, I couldn't complain or ask question why my sister has been tied up with the bed. So what I did, I just removed the rope and took my sister home.
Até hoje está aí em casa com as pernas inchadas. Nós vamos no hospital só para receber remédio da SIDA, só te dá remédio, você pode reportar, olha as pernas dessa pessoa. Eles não fazem nada. Diz, toma, ainda começam a me ralhar, e você que não está a dar bom remédio, não está a lhe dar remédio.
Since my sister was discharged, she's also diabetic and she's living with HIV. And when we go to the clinic, they will just give the medication, and when the sister will complain to the nurses, the leg is swollen. They won't even check on her. They won't even touch her. They'll just, they even on top shouted at her that you are not giving your sister the medication on the right time. They will just let her go. They say, just go. Here's the medication. They will leave the clinic and go home.
Sempre assim. A minha sister está aí com as pernas inchadas, mas essas pernas saiu com ele no hospital. Quando abaixou, não foi assim. Quando voltou, naquelas cordas que amarraram primeiro aqui, depois tiraram a corda aqui, amarraram no braço, aí onde saiu com essa dor de encher as pernas.
My sister, even she's taking medication, she's not changing. She's not getting any better. The legs, they are not going down. They are still swollen. Because you can see where they tie it. First, they started to tie her on the leg. And then when the leg was started to get swollen, they changed it to the arm. Until today, my sister is not getting any better.
Vai lá, reporta das pernas, eles não fazem nada.
Even I report, they don't even check on her, a proper consultation. They just look at her, they don't say anything.
Só me ralham, que você não dá bem remédio.
The only thing what she gets is a shouting from a nurse that you are not taking good care of your sister.
Pronto, assim mesmo, fechou.
This is all what I had. Thank you so much. My name is Monica. First of all, before I give my name, I would like to be also anonymous. And my name must also go to Sbongile, whatever you change to. Because why we want to be anonymous people? The clinic, like Sister Smangele said, we are not safe. They can even inject us with water and die. They say, you people, you are reporting us. So we are scared of our lives. Without wasting any time, my name is Monica Tlazana. I'm a Portuguese speaking. I'm staying in extension 39. Can I have interpreter in Tswana? Or we are fine? Okay. I also take medication at Unit 9 clinic. There was a time I couldn't go to the clinic. I asked one of the caregivers to go and collect my medication at Unit 9 clinic. The lady first was normally getting medication for me, but that day she was not available. And then I asked Sister DK if she can collect the medication for me at Unit 9 clinic, and she didn't refuse. She went with my particulars to collect my medication. After 2 days or 3 days, if I'm not mistaken, DK was not coming back to me with the medication. And then I had a meeting at the school, it's at Sing High School next to Unit 9 clinic. I have a set of twins there. So the principal held a meeting with me about my kids. So when I went to attend the meeting for my kids, I decided to go and see Sister DK at the clinic because I was already next to the clinic. When I arrived there, I saw Sister DK. I said, Sister DK, now it's been 3 days or 2 days. Where are my medication? She said, no, they didn't give me medication because on your file, they said you skipped, you defaulted. I said, wow, that's good, but I never defaulted. So I went to the nurse with my card. I took the particulars from Sister DK. I went to the nurse. And the nurse took me to the caravan where we normally take chronic medication. That day, all the nurses, the cleaners, like the sister said, the cleaners, they behave like nurses. They were all wearing orange T-shirts. So the name tag, it was written with the pen. I didn't see if you are professional, they were equally, they looked alike. So when I enter in the room, there were two. And then I asked, no, I'm here because you say this and that I've been faulting, date, there's no date. They say, no, let us see your file. They went to collect my file. It took more than 40 minutes for my file to come. And then the lady came, what is your name again? But sister, I give you my card, can't you read? No, the file, we cannot see it. I say, please, just go and see my file because you are wasting my time. And then that lady brought the file. Instead of helping me for what I went for, she started to read my history in my file. In my file, because when you are in this status, they will tell you about, they will teach you if you want to fall pregnant, what is the procedures you must go through. So the nurse wrote that in my file. And then she started to read my file history. Oh, you wanted to fall pregnant? I said, no. Can you please come out of that because this is my confidential story. I don't want you to read my thing. At the moment I was busy with her, another lady get in without knocking. She opened the door, there were 4 now. Instead of me and her, there were 4. I said, can I please have a privacy with you? She said, no. I said, no, ma'am, I understand Tswana very well. Don't crook me on Tswana speaking. I can speak Tswana. Rumanesi rotle, but na kirata bu privacy buame. So she was like having attitude nyana. So she came out. I followed her. Really, when we come to the clinic, when the nurses say, when they go this way, they like we must follow her wherever they go. So I followed her, and then Sister DK came. I started to explain to Sister DK, no, I don't want this nurse to read my history, because if I don't want you, even the doctor, if I don't want you to read my history in my file, I don't want. That is my confidential and this is my privacy. And then she started to speak in Tswana. Yeah, no, don't be rude. And she scratched my card. She scratched my card totally. I said, how can you scratch my appointment card? She said, because and then I was not feeling well with the hospitality that I get at Unit 9. I said, can I see the chairperson or whatever they call them, matron or whatever? And then they took me to a room. There were a nurse and a chairperson. And when we arrived there, I explained to the chairperson. So these 2 people, they were on the side of the nurse. They said, nah, you don't have to speak like this. She's a professional nurse. That's why they have the name tag. I said, I didn't see the name tag as a professional nurse. Because the way they are wearing, they're all oranges. Even you are wearing orange. You don't have a name tag. How can I know that you are a professional nurse? So me, I know a professional nurse with those stars and all that, but with orange T-shirts. I never saw a professional nurse with that T-shirts. So they were on the side of the nurse. If she wants to help you, before she helps you, she must go through your history. I said, no, I don't want my privacy. Because you nurses, you are speaking about our status outside. You are disclosing our status outside. If you see us, HIV, this is what we are preventing. So after that, the nurse said, no, you can go home. We're going to get the date. I drain blood once a year. Come May. I'm telling you, until now, I didn't go for blood. Even for the next checkup, I didn't go. So 2 weeks ago, a nurse called me, Sister Mapule called me. Metlazana, when are you coming? What, blah, blah. You never came for the next checkup. I said, no, I'm not here. I'm in Pomfret, but I was home. The next time, she's working with Sister Mapule, I don't know her name, at Unit 9 Clinic. She called me. Yeah, you were supposed to drain blood on May. Now you are not coming. Kirno, I have a problem. The reason I didn't come to collect my medication, I even lied to her. I said, no, I was pregnant, and then I get a miscarriage. Now I'm home. After healing, I will come back and get my medication. Until today, I didn't go to the clinic to fetch my medication. So this is the story I have. Really, the nurses are treating us very bad, especially we foreigners. We Portuguese speaking, even any foreigners, they are treating us very bad. If you don't know to speak the language, they will start to speak, yeah, boneba, bachakwa, eh, ba makwere. We are not kweres. We are African. We came here with the government. We didn't came here on our own. Even I came here on my own. You don't have to call me a kwere. So we are facing challenges at the clinic, especially the Portuguese speaking. Really, people, we are facing challenges, especially Unit 9 Clinic. They are not treating us equally, really. Thank you so much.
Thank you. Thank you, comrades. Before I read the recommendations, there are two things which I want to share with you here in the room and those who have joined the visual. One, March this year, we attended a SANAC plenary meeting. In that SANAC plenary meeting, we presented a damning report on shortages of medicines and stockouts in Northwest. The Deputy President of the country, Didi Mabuza, as the chairperson of South African National AIDS Council, promised us that he is gonna come down to Northwest so that he can make follow-ups on the report that we presented. I am glad to inform you, colleagues, that Tuesday and Monday, the Deputy President of South Africa, as the chairperson of SANAC and SANAC leadership, will be coming to Northwest for 2 days. One of those meetings, it will be between the Deputy President, the provincial and the national leadership of the PHIV sector. Comrade Neo and Comrade Themba Khatebe, as the provincial leadership of Northwest, you need to give, can you give it to Neo? You need to give this report to the Deputy President of the country, so that on his interventions, he is able to read that and familiarize himself. If you want us to give you a soft copy that you can email to his office before he comes here, so that when he comes here, he is familiar with issues that are raised there, I will die a happy man. Two, yes, yesterday, myself and the national organizer of TAC and Comrade Tubuto, we had a meeting with a community that is from Angola. We had about 50 people in that meeting. There are lot and lot of stories that these comrades shared with us of accessing services. In South Africa, we've got a constitution. Section 27 of the Constitution of South Africa gives rights, firstly, to the citizens of South Africa, those who work in South Africa and those who stay in South Africa. And this matter can never be left unattended, comrades. We can never call our African brothers and sisters foreigners in our motherland, which is Africa. From Cape to Cairo, Morocco to Madagascar, Africa is one. The existing borders, Berlin. So we cannot, as Africans, begin to discriminate each other and call each other amakwerekwere. We are with you. We need to form a branch there. Whether a TAC, whether a NAPWA, whether a post-defection campaign, whether a PWN, whether a Sanarela, we need to go to that community of Angola at Zone 9. We need to have a branch there so that we can be able to fight against these evils that are being perpetrated by these people. And we're gonna fight them. If those in authority are unable to fight for you, we will fight for you. If it means that we must take this matter to the courts in order for the courts to rule on your behalf, we are here, we are together. Comrades, our recommendations on this matter are as follows. 1, we recommend that the department must extend and implement the ARV refills from 3 to 6 months supply for all eligible patients. 2, retain government gazetted 12-month ART script and implement the March 2020 revised standard operating procedures on repeat prescription collection strategies with FEDILIT. 3, scale up the implementation of repeat prescription strategies to reach 60% of all people living with HIV and ensure 25% are accessing treatment from a community model and 20% from an adherence club. 4, the department and district support partners should discuss strategies with Ritshidze and the PLHIV sector on ways to restart adherence clubs safely during COVID-19, including options for making clubs smaller in size, meeting and also meet outside, etc. and etc. Thank you.
Thank you, Chairs. The next group of issues are on art continuity. People living with HIV lead complicated lives and may well miss appointments and even miss taking some pills. When they do, meeting them with support when they return to the clinic helps to ensure long-term adherence. Yet, poor staff attitudes and unwelcoming services remain a key challenge that mean PLHIV have stress and anxiety about going to the clinic or stop going altogether. For example, only 60.3% of patients thought staff are always friendly and professional. Most people we spoke to had never missed a visit to collect ARVs. Out of the few PLHIV who had missed appointments, 9 said they are sent to the back of the queue next time they come. We know the worst performing sites: Bapong CHC, Bafokeng CHC, Buitikong Clinic, and Litlhabile CHC, all located in the Bojanala Platinum District. 8 said they are reprimanded the next time they come. We know the worst performing sites: Tlhabane CHC, Bapong CHC, and Bafokeng CHC, still in the Bojanala Platinum District, and Juberton CHC, located in the Dr. Kenneth Kaunda District. What are the department and DSPs doing if talking about welcome back services and this is still happening? But we also have positive findings. 6 people living with HIV said they were welcomed. 13 people living with HIV said they were cancelled. We have site level data. It is possible to get it right. We should be learning lessons from the sites that are doing this very well and take this back to poor performing sites in order to improve. These graphs show that everyone we spoke to had gotten a viral load test in the past year. However, many do not really know what that means. The top 2 graphs are the results from when we asked people on treatment if these statements were true. 97.1% agreed with the statement. Having an undetectable viral load means the treatment is working well. And only 70.4% agreed with the statement, having an undetectable viral load means a person is not infectious. Yet, most people living with HIV, 93.5% to be exact, said that a healthcare provider had explained their results. Whilst the Northwest is doing better than some other provinces, the U equals U message is clearly not reaching everyone. Keeping people's HIV status confidential is a basic right for people living with HIV. Yet, too often, we hear reports of staff disclosing people's status or people's status being disclosed because of the line they wait in, or because they have to share a consulting room with someone. 22.4% of people living with HIV did not think that the facilities are keeping their HIV status confidential and private. The Northwest is doing the second worst against all other provinces in this regard, with only Limpopo doing worse according to Ritshidze data. 57% of facilities monitored present some sort of privacy concern, with reports of more than one person being consulted or cancelled in the same room came from Mahikeng CHC and Mahikeng Clinic. And reports of people living with HIV being separated from other chronic patients came from Bapong CHC, Hebron Clinic, Mukhwase CHC, and Mahikeng Clinic. This is a gross violation of people's rights and puts people off going to the clinic altogether. We will now proceed to the recorded community stories.
Ke tsa dipilisi tsa ARV ko Tlhabane Clinic. Ga ke gopola sentle ka zo ile kgwedi ya September and treatment yone ne ntse ke na le yone, so yaanong treatment ya me ne ntse ke na le boyfriend taka a itshwere mo ene, yaanong na le boyfriend taka ne re lwa a ba tshwara treatment ya me o itshwere for a kere maybe ke matsatsinyana mantsi, maybe a kere bo ma 5 ma ke 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 ba tlhalosetsa ke ba bolela tlhela go tlase ke simolola tlhakatlhakana ke shwa ke gatsela ke le ka mokgomong ke luza le momoro wa ka wa tlhaloganyo fo teng fo ga ke ya go teng ke ga ba simollanong ba le gone ba ntsela matsapa ba ntlhaba le mao e be le gone anong ba mpotse gore ke tsa treatment ko kae ka ba bolela ko room 3 file ga ke ilo batla file ko receptioneng ba njikisa gape ba re ga ba bone file ke tlamile ko bolela bone ba le gape bone ba mpotsa gore ka fale up and down until ebe ba simollanong ba ilo batla file ba ntšheka le mo systemeng gore ana ke teng ebe ba ntšheka ba re ga ba ke le absent le ka mokgwa mongwe ke le mo depressioneng.
Last year ka bo July last year ka July ke tlam yaanong dipilisi sa dine ke na le melemo go saene e solo ke na le selemo le dikgwedinyana melemo yona ya bolwetse bo ntšhweremo ke HIV ke ntse ke sa dine go tshwanetse wapa nako nngwe nako e raja ba itse ba gaedi nako nngwe phakela tsoga wapa re berekia ka nako eo nako nngwe e ka tlhola tse lotlhe tla go ja maitseboa e ka nna bo pharmacy ano bona bo pharmacy ka gore ke di tlogetse le ka taba diyo gone ke na re go siame tlabe ka re dijo ke a ithekela a ke amogetse yana kgwedi ya kgwela di a fela simola ke kopa khare ke kopa gombeole go itlhela mme a tla a tseswa ke a ke tseo na tliswa ke pitiki ka go nwa melemo ka nagana ga se siame mo go nna ka eletsa go ntse gore se tleliniki ke nagana gore ga nka tlisediwa melemo le dipilisi.
Thank you. So, here are our recommendations, comrades. 1, a circular should be issued that calls on all staff to treat people with respect and to withdraw the measure that people living with HIV who miss appointments should be sent to the back of the queue. 2, address all issues of staff attitude that leads to people living with HIV stopping treatment or disengaging from care, including by investigating all allegations made with regard to health personnel failures, including neglect and bad attitudes. 3, following this investigation, disciplinary action should be taken where appropriate and compensation be paid out to victims of neglect or ill treatment. 4, in order to continue progressing in this area, healthcare workers, including the Department of Health staff, implementing partners, staff, and community healthcare workers should provide accurate and easily understandable information on treatment, adherence club, and the importance of undetectable viral load when talking to people living with HIV through consultations, counseling, and health talks at clinics. Viral load test results should be properly explained to all people living with HIV in a timely manner. Often staff do not treat people properly due to stress, exhaustion, and burnout as a result of malfunctioning in the health system, including lack of time, tools of trade, equipment, or medicines. Better staff support systems should be put in place by the Provincial Department of Health in order to ensure staff wellness and support. Lastly, investigate sites with reports of people's HIV status being disclosed.
Thank you, GS. So the next issue we're going to look at is on index testing. While index testing has the ability to help identify individuals who may have been exposed to HIV earlier, if implemented in ways that cause harm to individuals, undermine their rights to consent, privacy, safety, and confidentiality, it erodes communities' trust of healthcare providers. We are concerned that screening protocols are not always being followed. 91.7% of clinics say that they always screen clients for intimate partner violence when they conduct index testing. This needs to be at 100%. 46% who do screen for intimate partner violence still contact all the partners regardless of reported violence. This is a major concern and violation of people's safety and privacy. What what is the point of the IPV screen if contacts are just notified of their exposure in any case? Now, in this slide, we see the people living with HIV perspective, where 37% of people living with HIV were asked to participate in index testing. 9% did not think they were allowed to say no or refused to give the names and contacts of their partners. 17.6% of people living with HIV said there was no IPV screen that was conducted in the first place. Furthermore, screening for intimate partner violence without adequate IPV services to respond to a client's positive screen is almost dangerous and unethical. We're going to go straight into our recommendations.
So, thanks, Comrade Ndivo. Under the index testing, we've got the following recommendations. The Department of Health and district support partners must ensure that index testing is always voluntary and that people living with HIV truly understands this. 2, the Department of Health and district support partners must screen to see if the individual's partner have ever been violent and record the answer to this question. No contacts who have ever been violent or are at risk of being violent should ever be contacted. 3, adequate intimate partner violence services must be available at the facility or index testing should not take place. 4, implementing partners must monitor all adverse events through a proactive adverse event monitoring system with follow-ups to assess 1, violence, disclosure of HIV status, dissolution of the relationship, loss of housing, or loss of financial support. Now, we will go to the next item, which is going to be led by Comrade Usimpiu on key populations.
Thank you, GS. One major barrier to HIV prevention and treatment services for key populations is being discriminated against at the facility, as we heard earlier. Primary health facilities are the entry point for more key populations to access HIV, TB, and other health services. Ritshidze interviews with key populations highlight the trauma that many key populations face when they try to access HIV, TB, and other healthcare services. It is very clear why some key populations do not access services or disengage from care altogether. It is also critical that key populations can access specific services to meet their specific needs. When we asked facility managers if they provide key population services, in some places they say they do. However, when we follow up with questions around what these specific services are, it reveals that services are not really on offer. So out of 14 facilities, only 2 said they provided services for transgender people, but for really, that was fewer. Out of 14 facilities, only 1 offered a full package of services. Only 14 sites, out of 14 facilities, only 2 offer PrEP, or pre-exposure prophylaxis. Out of 14 facilities, only 5 said they provided services for sex workers. In reality, only 3 out of 14 offer lubricant, and only 2 out of 14 offer sex worker outreach services. For example, out of 14 facilities, only 5 of them reported offering services specific for men having sex with men. In reality, only 3 out of 14 offer lubricant to men having sex with men, and only 4 out of 14 offer men having sex with men friendly STI and testing treatment. One facility said they offer services for people who use drugs, but none actually offered any services specific to people who use drugs. We will now proceed to community stories.
Dumelang, le kae? Ke nna Millicent Sebotsa, ke tswa ke le ko Klerksdorp, Dr. KK. Nna story sa ka se botlhoko. Se botlhoko bo le goreng se nledetse mo le goreng ke stopile medication wa ka. Go etsagetseng ko clinic e ke e tsamayang ke Empilisweni Clinic ko Jobetina. Ko clinicing ha gona motho se itseng ko Jobetina gore Millicent ke mang. Millicent ke a transgender woman.
Afternoon, everybody. My name is Millicent from Klerksdorp. My story is very painful to a point that got me here. So where I come from in Jobetina, there is nobody that doesn't know Millicent to be a transgender woman.
And last year, go Empilisweni, yaka ke tlhola ke ya ka di appointment tsaka.
Year before last at Empilisweni, just like I go anytime when I have appointments.
Ki ile ko clinicing, normally I cross dress.
I went to the clinic and as normal, I cross dressed, meaning hore o apara diaparo tsa bomme.
Ha ke kena ko clinicing ki tsitse buka ko pele.
When I went inside the facility, I had to give them a book at the reception.
Ke registera.
To register?
Ha ke ntse ke registera ngwanyana o nang registera a ke mitse mo ntshanyana. Then o badile mabitso aka ha fitla ko ID number ya ka a ba imisa tlhogo a ntsheba.
When I got there to register, the lady who was assisting me, I don't know her name, but she seemed new. She looked at my registration book, which is probably my card, and my ID. And then when she saw the difference, she looked up at me.
Abampotsa go ke buka ga mang ke amora ke re ke buka ya ka. A re kwena Thabang Sebotsa ka re ke nna Thabang Sebotsa.
She then asked, whose card is this? And I told her that it's mine. She asked, am I Thabang Sebotsa? And I agreed that yes, that is me.
Abampotsa gore why ID number ya ka e fella, why ID number ya ka e le ya male.
She asked, why is it that the last numbers on my ID show that I am male?
So ga ke tshwanetse ke explain. Ha ke mo explainela ba re ke bua sekgwa se se deep.
I then had to explain to her, but when I explained to her, she said that I was speaking deep English.
So kamera ke re ke kopa re se itlhako because of hakatlela eno. So ka tswella ka tsaya buka ya ka ka dula mo fatshe, so a discussa le o utana ditse motho gagage.
So I then said to her, I didn't come for that, I came here seeking help, so can we not take this discussion any further? She then continued to discuss me with the gentleman she was sitting with while I went to take a seat in the facility.
After nakonyana ke ntse ke dutse a tswa a tsenela ka ko consulting room, a bua le motho ana bua le nna ke tsena bua le bo mang ka mo.
After some time, she then moved from reception, going to one of the consultation rooms, having conversations with other people. I'm not really sure who she was talking to in the consultation room.
Mara ke ne notice gore go na le batho ba ba tsenang ba okomela ka mo re dutseng ka mo teng ba tikela.
Okay, but I noticed that some people would come in and out of the consultation room to basically take a peep at me and then go back in.
Ha ile tene ya ka go kena, ka kena ko counseling room. ha ke kena ko counseling room ke tla ke dumedisa ke fana ka buka ke bua gore ke tletse mo tleliniking ke ne ile for treatment and other services.
So when I went into the consultation room, I gave them my card and explained who I am and why I had come to get the services. I then went to get my treatment and for other services that I had to get at the facility.
I kinile for counseling thing. Ko ke kerile ke le confused. The lady sa pele sa simolotseng ka sona a itse I'm a Christian. Before I introduce mo gona a itse nna ke mo Kriste.
What happened in the consultation room was that before the nurse assisted me, what she said first before anything else was that she is Christian.
Ke bo emisa ditsebe ka go ya no nna ke vocal ke mo file chance ya gore a bue sa batlang go se bua a bua gore o kopa go nkopela somebody o tla nthusa because of ena hana go khona go nthusa.
So immediately when she stated that she's Christian, it raised my eyes and I was like waiting to hear what else she had to say. She then continued to say she's not going to be able to assist me, but she can ask somebody else who's going to assist because of her religion. And because I'm a vocal person and I'm able to speak out for myself, I then allowed her the space.
Ona bitsa ngwanyana o mongwe ba dula ba le babedi. So instead of anthuse dilo tse ke di batlang, ona mplela ka di Bible chapter gore ke se bi go dira eng go go etse o mpoleletse dilo tse dintsi tse le gore tse ding ke ne mo mametse ke sa motho cause ka mokgo ke ne bipetse ka teng go no sa batle o etse ke sa batle nix.
So she then called another lady, a nurse I assume, and then they sat with me together, both of them. But this lady that had said she wouldn't be able to assist me because of her religion, then continued to quote Bible scriptures at me, trying to explain how the Bible speaks of homosexuality as a bad thing and a sin. The way I was so mad and angry at that time, there's things that she said that I couldn't hear, but I was listening.
Ha ba fetsa go bua ka dula le bone ka ba workshop ka dira a smaller nyana workshop for bone. So ka ba kopa go ke kopa le didimaleng le mmameleng. So ka ba workshop ka ba tlhalosetsa gore ke nna mang, transgender ke eng, why ke identify as a trans woman, ke ikutlwa yang go diragala eng. Ha ke fetsa mo.
So I allowed them time to finish conversating or talking and gave them a mini workshop relating to my sexuality and how I feel, why I identify as a transgender woman, basically giving them a highlight and a background of what it means to be trans.
Ha ke fetsa mo still me o are mo gonare ka go utlwa go bumpuela sekgowa ebilane o mplela dilo tse di buang mare nna ke ne re lentswe la modimo lege wa go tshako di heleng.
So after I finished giving them the mini workshop, what they then said was they hear and understand everything that I'm articulating, and I'm speaking seriously deep English. But what remains is that I'm going to die and go to hell because of the sin that I'm committing by being trans.
And ka kopa go ema ke tsamaye. So ba ntsenyetsa medication wa ka mo pampiring e brown ka tsa medication o ka tswa hang explainele nix gore ke eng mo ha re nix ke bitswela.
I then requested to be excused from the facility. What they then did was give me medication to which no explanation was given. I didn't know what was the medication for and how to take it, but I just took it and left the facility.
Ke ne utlwile botlhoko thata ke a tsamaya go empilisweni ha ka bua le ope ka itlha le ko tlong go gore ha ka founa ha ka ra mang nix ke tlile ka lla ko tlong ka itulela stele and ka decide gore ha ke sa tlhola ke tla ya go empilisweni.
I was really hurt. I couldn't speak to anybody or tell anybody of my experience. So I then decided to go home, cried myself to solace, and decided not to ever go back to the facility, which is in Mpilisweni.
Ke dutse nakonyana ke sa nwe treatment. So last year, February, I was reinitiated more LTD by Gay Umbrella, more for programming yesterday.
Okay. So I then defaulted from my treatment, my ARV treatment, because of this treatment that I received at the facility. But last year in February, I was reinitiated by another NGO and was initiated on TLD.
Se ke ratang gore department e sitse or e se dire ke gore re tlhoka our counselors ba sensitiziwe.
What I would like the Department of Health to do is to sensitize and teach or train the HIV counselors.
Especially LGBTI people.
Especially on issues relating to the LGBTQIA+ community.
And transgenders.
And particularly transgender people.
And our MSMs have the clinic because of stigma and discrimination.
When I take a closer look at things, even people that we regard as men that sleep with other men are afraid or do not use services from the facilities because of the fear of being stigmatized or discriminated against for their choices.
Because of bongata ba bone, now professionally I'm a counselor, HIV/AIDS counselor. Tlabe counselor MSM, tshwantse ka go initiate wa go clinic tlaba ha ke lwena go clinic because of ha ba mpona ke tsama lwena ba go bona tla gore ke wa lona ke wa leloko.
So as an HIV counselor myself, I am able to say this about MSM because after I have to initiate someone on treatment, they then have to go to the facility. I have to refer them to the facility. They always say they're not going to go to the facility to collect the treatment because even if she goes with them to support them in matters of accessing the treatment, then the clinic staff is going to be able to group them and know that they are MSM and they are not yet comfortable with being exposed to such a situation.
So now, ke tsamaya go Park Street Clinic because of go Mpilisweni ke boniwa ka joke. Ha ke tsena go Mpilisweni ke serekisi because of ke dressitse as a woman, identify as a woman, and at one point somebody kila nare obuti brother so mo gona ene gore khaintsentse matlo.
I now use another facility because at Mpilisweni I am seen as a joke and made to be like a circus in front of people. There was a time where somebody addressed me as brother, and obviously I'm not comfortable with that. But other people around and even staff are entertaining that, so that is why I chose to change the facility.
And ke one ya di clinic tse di leng gaufi thata le nna. So most of LGBTI people or MSM around Mpilisweni, they go far to other clinics because of their discrimination and stigma.
Mpilisweni is the closest clinic to myself and other members of the LGBTQIA community that I know, but all of us are not comfortable with using the facility because of the reception at the clinic. So we all then choose to access healthcare services from other facilities which are most of the time far from our reach. But because of the services at Mpilisweni and that treatment based on our sexualities that we get, we choose to rather travel further than go to Mpilisweni.
And before ke lebala, before ke tlogela go ya ko Mpilisweni, ke kwetse lekwalo ne ke bo le kenya mo complaint box.
Before I stopped going to Mpilisweni, I had written a complaint and put it in the complaint box.
And batho ba ba na le teng ko ba ke ba sileng ba fotse mo ba re le before ke fitla ko gating ga setse butse go ntshitswe go baliwa gore ke kwetseng.
So some of the people that I had left queuing in the facility that know me told me that chances are, even before I left the gate, looking at the time interval, before I reached the gate, my complaint had already been removed from the complaint box by the staff at the clinic.
So ke wisha gore re ka user di services tsa di clinic tse di gaufi le rona re sa tshabe gore ka o sane tla be go bua ka di status tsa rona o go bua ka di problems tse re di sitseng ko clinicing.
I wish that we could be able to use facilities closest to us because of convenience without having fear or risking our statuses being disclosed or being ashamed or shamed at the facility by being discriminated or stigmatized because of our sexualities.
Thank you, Kaleboga.
Thank you so much.
Dumelang bagolo ka le dumedisa.
Afternoon, everybody. I would like to greet all of you.
O buang o ke Refilwe Motlhambe.
My name is Refilwe Motlhambe.
From Motlhabeng.
From Motlhabeng.
Ke tlo go bua ka se leng gore ke se experience itse nna self go Motlhabeng clinic.
I'm going to talk about something that I particularly experienced at Motlhabeng Clinic.
It was this year ka March.
It was this year in March. I had sustained an injury from a soccer game.
Then like sharp, then decided I go to something for
I wasn't okay and I was in pain, so I decided to go to the clinic to get assistance so that I can be relieved of the pain.
Then I decided
I then went to the clinic.
Then I get to clinic.
I got to the clinic and sat without being assisted for hours.
For sure, 4 hours or 5 hours, and by that time, obviously in the emergency, because by that time,
it was probably 4 to 5 hours that I had waited to be assisted at the facility while in pain, and I would like to conclude that my case was an emergency but was not attended to as such.
Mare ha ke tla go sheba go na le batho ba ba thusiwang ko morago ga ka, but ke feletsa ke ipotsa gore it is because of my sexuality or what.
So I realized that other people that were behind me in the queue were being assisted before me, so that raised questions with me with whether or not am I ignored because of my sexuality,
or it's because of I cannot favor, there is no one no longer go as a nurse.
I also even asked myself, okay, maybe I'm not getting assisted because I do not know anybody in the facility that would help me quicker to skip the queue or just be assisted at my time.
It's all dula sebaga around boma 4:30.
I sat for a very long time, and around 4:30 was the time that I got assisted. When I got inside the consultation room, there were 2 ladies who are nurses.
Uncomfortable. I should go home, but while deep inside,
I really felt uncomfortable. It was so uncomfortable and so unbearable that I wanted to just leave and go home. But because of the pain on my foot, I was unable to do so. I needed their help.
Then when I get they bit baba simula ba mpotsa di questions tse dintse gore ke dlala yang bolo, and nurse imagine ke dlala yang bolo ke le ngwanyana ke tira somebody mo nna, then that's why I end up getting injured, something like that.
So before they assisted me, what they said was, why are you playing soccer because you're a girl? And the reason why you got injured is because you want to act like a man. Then this was a professional nurse, mind you.
And this was very painful, inhetile too much.
That was very painful. It hurt me so much.
Ke rapela gore ba mfe do tsaka tse ke tse leng gore ba nthusa ka tsone teng ke tswe ka tleliniki.
I was forced to then beg them to just give me the medicine that's going to relieve me of the pain so that I can leave them and leave the clinic.
And ba rudi le rudi. My sexuality has nothing to do with them.
They were very rude, but what they need to understand is that my sexuality has nothing to do with them. I had went there to access healthcare services. What they were supposed to do is assist me with the that I had come to.
So ke ipotsa gore like why re tshwantse re tsewe yalo a re tla tshaba go go ditleliniking go thusiwa because of dipuo tsa di nurses.
So I ask myself, why are we treated this way? This makes us stay away from using clinics because of the treatment that we get from the nurses.
Because sometimes o tla lwala o lwala bona go lwena wa lwala, but iso go ha o batla go tleliniking just because the way re tsewang ka teng.
Sometimes you get so sick that you're assisted through medical attention, but you choose to rather stay at home because you know that going to the clinic is going to make matters worse based on how they're going to receive you and stigmatize you for your sexuality rather than focusing on attending to you medically.
Na ke a rata the way ke tshotse ka teng ko Motlhabeng tleliniki. There were two nurses, ha ke a rata attitude ya bone, they were rude, and ha ke a rata ke tsile le ko Motlhabeng tleliniki ke utlwile botlhoko.
I did not like the treatment that I received at Motlhabeng Clinic at all from both those nurses. It hurt and it still hurts even now. The treatment that they gave me and focusing on my sexuality instead of assisting me with the challenge that I had come with to the clinic.
It doesn't matter how sexuality rona e yang, but also we are humans.
My sexuality does not matter. I am human. Where's the center part?
Thank you. Thank you. So, we have the following recommendations. Key populations lives everywhere. The Department of Health and district support partners must provide key population specific services at general clinics, not only through drop-in centers, including training staff to provide key populations friendly services and at least provide lubricants, outreach services, harm education services including medically assisted treatment, hormone therapy, PrEP, STI testing and treatment information packages. The department should ensure that all clinic staff are sensitized on provisions of key population-friendly services for sex workers, people who use drugs, men who have sex with men, and transgender people. We're moving now. This is going to be the last one, eh? Yes.
Thank you, GS. So we're now going to look into the issue of tuberculosis. In
So what happens is when you put on TB treatment or when you initiate it, they have to check your body weight.
Sorry. So motemo ke ne ke le less than 40 kg.
So at that time, I was less than 40 kilograms,
Gore pilisi ne ke santse ke di tseye di na le number mo ntle mo boxing.
meaning that I was supposed to be given a certain milligram of treatment.
Go na le e ba e bitsang ba re ke 152 something.
So there's different numbers of the milligrams.
So bane ka kgwedi ya ntlha ba neile 150 le 300.
So on the first month, I was given 100 milligrams and 300 milligrams.
Yaanong ga ka tla ka ba botsa sepe
I did not ask anything
ka gore ke patient akere
because I'm a patient.
ga ke nurse.
I'm not a nurse.
Ke di tsere yalo kgwedi ya ntlha ka tsamaya ka dinwa di sa tlhalosiwa gore ke dinwa yang mo boxing go dirilwe 1-1.
So I took them and went home without being explained to how I must take the treatment. But on the box, it was written 1-1.
So ka dirisa kelello ya ka kare okay go ra re mo paketeng e ke tsa pilisi e 1.
So I used my brain and concluded that it means on a certain packet, I'm supposed to take 1 pill a day,
hela yalo le mo go yeng.
and so as the other.
So go na le tse dingwe tse di mo containing e white
There's other tablets in a white container.
di kwetse iso something.
They are written isoniazid.
Aha. Le yone go kwadilwe 2.
On it, it's written 2.
Plastic nyana e nngwe e kwadilwe proxy something ha ke itse maina teng.
There's another tablet that's written proxy something. I
Go
don't know.
kwadilwe 1 le yone.
It says 1.
So ha ka butsa le gore ke di tseya bosigo or phakela or ga ka directiwa ka sepe mo medication.
I did not ask, and I was not explained to if I should take the treatment in the morning or later in the day.
So nese o di tsere a di ba mo godimo ga tafole
So the nurse just took them and put it on top of the
a be
table
a tswa a sena kwala di one tso tsa gagwe.
and then left after writing those numbers on the tablet.
So ke motho o mongwe ha ke le mo officing or ke le somewhere mo ke bonang chat teng ke batla go bala gore go kwadilweng.
So because I'm a curious person, when there's things around on the wall, I started reading the information that was on the wall.
And then mo ne ke dutse teng ne ke shebile kwa a nshebile so motho ko ga rona mo gona le TB chart.
So while we were sitting, I realized there's a TB chart to the left of the consultation room where we were sitting.
Gona di kg le maina a pilisi kam.
There's body mass index and the names of the treatment, including the numbers or milligrams of the treatment.
Tse di kwadilweng mo charting tseo ke tse di mo godimo ga tafole.
What was written on the chart was what was on my table.
Anta a tla ka yone pampiri brown a di tsenya anta a re o tla next month ka kgwedi ya ka dikana.
She put the treatment in a black bag, a brown bag, and then gave it to me to say, you must come back next month to collect more of your treatment.
Still ha ka motsa sepe ke tsere ka tsamaya ka tla ka next day te ampetseng yone ampha the very same thing.
I still didn't ask. I took the treatment, went home, adhered to the treatment, came back on my appointment date, and she gave me the same treatment where I didn't ask any questions, even though I was seeing that the chart was saying something different.
Yaanong mo kgweding ya bobedi ye cause ka ke motsa gore sentle treatment e ya TB ke tlo go tsaya sebaka se se kae.
So on the second visit, that's when I asked, for how long am I going to take this TB treatment?
A be le gona reng oh eish ke lebetse kgwedi e fetileng go go tlhalosetsa o tlo go tsaya go seta dipilisi e one kgwedi tse pedi.
So she then said, oh, I forgot to tell you when I initiated you that you are supposed to take the first set of treatment or tablets for 2 months.
And then ntlabe re go checka gape e be le gone o tla yang ko go engwe.
And then we'll weigh you again and then move you to other treatment.
E be ke mmotsa gore ke kopa go itse ke dipilisi tse feng tsa ntlha tsa bobedi ke tse feng.
I then asked which of the tablets am I supposed to take for 2 months first and then which ones will follow.
Kana go fa ke botsa nurse.
I was asking a nurse at that time.
Ke shebile chart gape.
I'm also looking at the chart.
O mpontsha dipilisi tsena tsa box e white ke line 1.
She was showing me the tablets in the white box saying
Ka
that,
jika tlhogo ka sheba chart.
and then I compared that to the chart.
Mpontsha box ya bobedi gore ke line 2.
She showed me the second box, that it's line 2.
Ka jika tlhogo gape ka sheba chart.
I then referred also to the chart.
Be ke re okay kgwedi a ntlha o mphile dipilisi tse di ntse hela yana.
I made her aware that on the first month, she gave me the tablets just as they are right now on the table.
Le kgwedi ye o di mpha fela yalo.
And now it's the second month you're giving me the same treatment that you gave last
And
month.
o ntha gore ke o tsaya dipilisi tse for 6 months.
And you're explaining to me that I'm supposed to be on this treatment for 6 months.
So ebe ke mo raya ke re, ke kopa o ntlhalosetse sengwe fa.
I then asked her to explain something.
A gona le tse dingwe tse di seng fa tse ke tlo go di kry-ang gape ha ke fetsa 6 months.
Is there anything that is right now on the table, one of the tablets that I'm going to continue with until I finish my 6 months treatment?
A ba re di teng mme yaanong seno tshwanetse se diragale o ne o tshwanetse o kry-etse tsa box e tshweu kgwedi tse pedi.
She said, yes, there are. What's supposed to happen is for you to get these tablets in the white box for 2 months.
And then tsa box e khibitswang yana 2 months.
What is Kibitsonyana? And
Red.
the other color box, the red box, for another 2 months.
And then a ba bula cupboard
And then she opened the cupboards.
a batla ka dipilisi tse dingwe gape ke box e tona yaanong e brown
Came with a bigger brown box
a ba re tse ke tsa bofelo.
and said, these are the last part of your treatment.
So ha ke mmotsa gore ha o mphile line 1 le line 2 ka kgwedi ya ntlha, line 1 le line 2 ka kgwedi ya bobedi re bereka yang ha go ntse yana.
I then asked, how are we going to move forward? Because she had given me the regimen 1 and regimen 2 on the first and second month.
A ba re dipilisi tse ke tsa TB tsotlhe akere.
And then she said, all of these tablets are for TB.
Ebe ke re emma.
And then I said, yes.
A ba re ko bohelong ba letsatsi ba go dira so se so one.
She then said, at the end of the day, all of these tablets are going to do one job.
Wana tsamaya go na dipilisi.
You go and drink the tablets.
Nako ya teng ke sene ke sena boikgatelo because ke ne ke palelwa le ko tsamaya.
At that time, I didn't have a choice because I was even unable to walk.
Ke tsere dipilisi tse ke le ha ke nonne. Ke tsere dipilisi tse ke kwakwapetse fela gore ha nka busa mmele wa ka.
When I was taking the tablets, I was so sick and had lost so much weight that what was my priority was to just gain a bit more weight and come back to being myself.
Ha ke ntse ke tsweletse ka tsone ka ba 2 worse yaanong.
When I kept on taking the treatment, I got worse instead of getting better.
Ka ba botsa gore dipilisi tse kgwedi ya ntlha ne di siame fela di ntse isa sedidi go nanong ha ke sena ke dino ke lala ke kgwa bosigo botlhe.
So I then asked them what was the difference between the tablets, because for the first month I didn't have challenges, but on the second month when I was given the treatment, I started feeling nauseous and would cough out sputum the whole night.
E ba re ha di ntse ke go ra gore o tlhola o di tlodisa go ra gore ang kudini.
They then said to me, if that is the side effects that I'm experiencing, it means I'm not adhering properly to the treatment.
E be ke itidimalla.
Then I kept quiet.
Go tla gore ke kgwedi ya bobedi ke kgwedi ke fetsa 6 months anong ke the last 2 months.
I was now on treatment for 4 months, looking at the last 2 months of my treatment.
Ba mpha dipilisi tseo ka tsamaya before ke tsamaya e be ke botsa nurse gore nurse wa gopola kgwedi ya ntlha ke go boditse ka dipilisi.
She gave me the tablets, and before I had left the facility, I asked the nurse to say, remember on the first month, I asked particularly about my treatment.
A ba ntha re e.
She said yes.
E be ke re dipilisi tse no mpontsha tsone di re ke line 1 go ra gore I was underweight.
So I then made her aware that the tablets that she had given me, checking the chart, say it's regimen 1 and I was underweight.
O bompha tsone the following month gape di ntse hela yalo.
You gave me the same set of tablets the following month.
Be ke motsa gore a mme ko morago kwa o ntse o sang over medicate or under medicate.
I then asked her whether or not is she sure that she had under medicated me or overdosed me on the medication.
A mpotsa gore ke ha mpotsa potso ntseng yalo.
She asked why would I ask such a question.
Be ke mora ke re kgwedi le kgwedi ke ntse ke shebile chart ele.
I then told her that every month when I came to collect my treatment, I would refer to the chart.
And then ha ke tla go shaba di results tsa sputum ha o di mpolelle gore di ntse yang.
And when I come to check for my sputum results, there is nothing that is conclusive.
Ka bora karabo ya ga mmelo e ne le gore o mpoditse gore o bereka kae.
So her response was a question in the sense of, where do you work?
E be ke molela nnete ya ka ngwana ke mora ke re ke facilitator ko Red Cross.
I told her that I'm a facilitator at Red Cross.
The final answer ya ga ne le gore ka gore o itse go bala.
What she said to me was, because you're Leonard,
ha o tlhoke gore ke o tlhalosetse gore treatment ya go bereka yang.
you then do not need my explanation on how the treatment is going to work.
Sa bohelo na se ke se dirileng ke dirile mmereko wa ka.
What is left at the end of the day is that I did my job.
A ba ntlogela ka mo consulting room a bataganya setswalo.
Then she left me in the consultation room and banged the door.
Ka sala ke maketse gore ke ipotsa gore a ke ka ke tsamaye kapa ke nne o latetse tse dingwe kapa go diragalang.
I was then shocked and confused on what to do because I wasn't sure whether she had left to collect more treatment for me or what was happening at that time.
Se se botlhoko ke gore ha ke tswela kwa ntle
What I heard was when I went outside,
ke mo itlhetse a emele matron
I saw her standing with the matron
le me o kolomakang
and the cleaner
ba bua ka nna
talking about me
mo pele ga di-patient tse
in
dingwe
front of other patients.
ga ke tswa ka kgoro ka bitsa leina laka
When I walked outside the door, I took her name.
gore Freddy kgwasi ha tla mo nka se tlhole ke mo thuse because o na le dipotso tse di tlapelang
Oh, she had took my name and then said, Freddy Khwasupe, when he comes here again, I will not assist her because he has questions that are irritating.
so e rile ke tswa ka kgoro matron a ba re a ko wena Freddy
When I walked out the door, the matron asked, are you Freddy?
batho botle ke ga ba chika ba ntšheba
Everybody turned around to look at me.
matron a re o irwa ke gore o tla wa apere ya ka mmotlara mo tleliniking
So the matron said, my behavior is justified by the way I dress as a model when I come to the facility.
mme wa matron mme wa la cleaner a ba re ke di-gere di itse di ntse yalo
The cleaning lady then said, he is gay, that's how they are.
so ka ke sena le mafoko ke eme ka mo shebelela mme o le ka sheba matrone
I had no words at all, I was lost for words.
se ne se le mo go nna e ne le gore ke latlhe dipilisi tseo ke tsamaye
I just stood there looking at the matron, looking at the cleaner, and
Mare
had a feeling of throwing away the tablets. And
mare e rile ke tswa ka gore ke dirile decision le monagano wa ka
but when I left, I had made a decision with myself
gore ko tleliniking ya Denville ga se ko ke tla tlholang ke boela teng
that I will never ever go to Denville Clinic ever again.
ka change ka re ke ya Lompark
I then went to Lonely Park.
ko Lompark ga o simolola o tsena fela
At Lonely Park, as soon as you walk in,
bomme ba ba kolma le go nanong ke santse ke bereka le bone bomme ba ya ka re bua
the ladies that are cleaning at the facility, which I work with currently,
go simolola nurse ha le tsena phakela
it starts with the nurse when you come in the
a
morning.
go ha attitude o heta ka pharmacist go itlhela ke go mo kolomakang gape
They all give you a bad attitude, from the nurse to the pharmacist all the way down to the cleaner.
ba feletse ba bolelele di-patient bomme ba ba kolomakang gore o wena o tshwanetse o ile go testa wena o testa HIV
The ladies that clean the facilities have the guts to even go as far as telling patients in public that you should get tested for HIV.
ke ga ba ntha yalo malaba ka last week la boraro ke go tlhola
That's what they said to me when I was coughing a week before last.
ba re go amakatsa gore bole health worker o go tlhola
They said it's shocking that as a health worker I'm coughing.
ene ka tselo leng ka teng o ka re motho a tlhoka go tsaya madi
And the way you're so slender, you look like a person who needs a blood transplant.
so ka gore ke na le lerato la bagolo
But because I love elderly people,
ke ba shebile fela be ke tswa mo go bone ke re ko bofelong ba letsatsi ke a go complainela mo go mang ha o tsenya complain ya go mo suggestion boxing ha o jika ba e ntsha mang le mang a go shebile that one I can testify
I just looked at them and said nothing.
so re
And at the
kopa
end of the day, it was useless for me to even write a complaint and put it in the complaint box, because as soon as you walk out, your complaint is removed.
so re kopa thuso e ntsi thata ka di-cleaner tsa rona
We need a lot of help when it comes to our
ka
clinic,
di-health worker tsa rona go gotlhe
health workers and every other professional.
because ko bofelong ba letsatsi re setse re tshaba le go itesta re le ko tleliniking
At the end of the day, we even get afraid to test at the clinic
because ra itse gore ba go bua
because we know that they're going to disclose your status.
ke a leboga
Thank you.
So these are very powerful stories. And we have TB as an indicator, because TB remains the leading cause of death for people living with HIV in South Africa. And as Ritshidze, one key area we monitor around TB is the level of TB infection control at our clinics. We asked 7 questions to assess TB infection control at clinics outlined on the graphic on the left. No facilities in the Northwest were awarded green status for checking all 6 best practice measures on the scorecard. Ritshidze scored 7 clinics yellow status, and this translates to 50% of the clinics being monitored, following about half of the best practice measures for infection control. It leaves 7 clinics, or the other 50% of clinics surveyed, failing altogether at meeting these 6 basic best practices to stop the spread of TB. I'm now going to hand over to the GS to take us through our recommendations.
Thank you again, and our humble apologies about the glitch One of the enemies as people of South Africa that we must fight is load shedding. Because load shedding is messing up with our lives. But we're gonna talk about it some other time. So the recommendations we have are as follows. By the end of September, the Department of Health should carry out a full audit of all public health facilities in the province to assess whether sufficient TB infection control measures are in place. 2, the Department of Health in Northwest must send a circular to all facilities to ensure that 1, all windows are kept open, TB infection control posters are displayed in visible places in the waiting area. Patients to be screened for TB symptoms upon arrival integrate with COVID-19 screening. People coughing or with TB symptoms to be seen first to reduce the risk of transmission. People who are coughing to be separated from those who are not while waiting. Where infrastructural issues mean that public facilities creates a TB risk factor, e.g., they are too small or there is poor ventilation, an urgent, fully funded turnaround strategy must be developed to outline how these challenges will be rectified. So these are the recommendations that we have on TB. As we are about to close, we're gonna give 3 minutes before we give to the Northwest Department and National Department. We're gonna give 3 minutes, colleagues, to 3 leaders, 1 a leader from NAPWA, 2 a leader from Sanarela, and 1 leader from TAC, just to comment or say something on everything that has been said here. But we must be mindful that time is against us. I will call upon Comrade Themba Khatebe from NAPWA. There is Themba next to you. Comrade Themba for 3 minutes. And then after Themba, it will be Bishop Harane. After Comrade Bishop Harane, it will be Comrade Tsolofelo, in that sequence.
Thank you. Greetings, everyone. Sanbonani. Amandla. Forward with great health service. Forward. Thank you, SG. I did some notes since I was here listening to the speakers who have been sharing their testimonies and experiences. And out of the notes that I did, it's a lot that I might share, but having been given 3 minutes, I'm going to quote mainly in the sensitive part of it. I'm going to start by underlining number 1, stigma and discrimination, which is breaking the confidentiality clause in the facilities. According to human rights violation, your confidentiality should be taken to note. For human rights violation, we've got clause that says respect, dignity, and confidentiality. There are 3. Thank you, SG. Looking in such, your confidentiality when it's broken, it's a criminal offense. It's an offense. It's a dismissal on point. Having said this, all officials, they know when they sign their contracts of employment, the confidentiality declaration is signed, which says they will respect, they will follow, and they will keep the confidentiality of the clients on the high standard. With that being said, it means all those guys who have violated you or who have broken your confidentiality, they have none other than terminating their contracts of employment. I'm going to move straight to data capturing. Almost in all facilities in Northwest, we've got a challenge with data capturing. In Dr. KK, they created a system of a notebook, which in other areas, that system is not created, whereby the notebook will be tracking effectively, accurately so, to say, when was your last visit? It has a semi-history of your illness. But looking in the other areas, there is no kind of such notebook, which is one system that some areas can copy. But unfortunately, the data capturing in Dr. KK will always underline you as a defaulter, even if you have that kind of a notebook, which at the end of the day, is either the problem is with the data capturers, or the problem is with the archive system, or the problem is with complying with the duty that one is assigned to do. But we need to look into such as well, so that people should not be considered or regarded as defaulters, whereas you are following your treatment. Number 2 bullet in defaulter rate. The defaulter rate is also encouraged by the people who are discriminating, people who are incompetent in their duties. Because most of people who've been talking, they stopped taking their treatment because of ill treatment from staff. That is another concern, which is so important. In my closing statement, I will say, most of you colleagues, most of you comrades, most of you as society, we are self-activists, because all your testimonies were well articulated to a sense that they are evident themselves. If we were to put 2 analysts to analyze in all these testimonies that have been shared here today, we would say we've got a concrete case to have people contracts terminated with immediate effect. I salute. Amandla.
Thank you, Comrade Temba. That was Comrade Temba from Napwa. Gogu sizawucela uBishop Harane from Sanarela. 3 minutes, and then we go to other comrade from TAC. Over to you, Murut.
Dumela Magacho. Bishop Anko to now 3 minutes. I am a ball beating, I know 3 minutes. On to Buatata. The Halampino Mataka Harele, Fanda, ready to me. SG Levatama Lebone, Le Muruti, Muepi, Le Mataka, we didn't say one or again. Sales you boiling low. Says the Galamon Northwest. The whole Northwest, how we are good thing, SG, what we call as Lolosealas. But about push over Kamu Pushum. Give on a manes. Give my councillor. Give my parliament. Give officer primi. Give officer the MEC. Ian Pert's price. Our translator.
Except
Why is the colleagues is one? Let Kosala Gargarona. I was a cause, had I got translative. Maranganal was to and how translative. As a politic. And that SG live out some Lebonele boat.
Thank you so much, GS, and everybody that you came with. Thank you for coming here. I have a tiny, itty bitty bit of a complaint, please. You do such things, you bring such events in the location.
But
people from rural areas don't have any information. We should have taken this event to Lonely Park.
Or Diachuan.
Or Diachuan.
Or Majamanchu.
Or
Ritshidze Homena.
They would have known what Ritshidze stands for. But it's okay, GS. Here is my plea. Can the Ritshidze team in Northwest,
especially Mahikeng,
especially in Mahikeng,
re bereke mmogo,
let's work together.
re tsamaye kereke ka kereke.
Let's go and visit churches.
Ka gore dilo tseo di buang tse HIV mang di ko kerekeng.
Because every of the diseases that we're discussing are there in churches.
Mara o ele tlhoko go na le baruti ba ba sa tswong ko modimo, go na le baruti ba ba tswang mo bathong.
But you need to pay attention to the fact that some pastors are not from God but from people.
Ga ke batle go bua thata go tse 3 minutes.
Let me not waste my time. I have 3 minutes.
Le go la mela boelo ke gore
My last word is
go na le monno mongwe
there is a man
a re santla
who said first,
o rate motho,
love a person,
o mo tlotle,
appreciate a person,
o mo rerise,
preach
o mo direle,
and work for a person.
o mo itshokele.
Understand the need of having a person.
Ke go ra gore o rawe
What I'm saying is
o re rate,
love us,
o re tlotle,
appreciate us,
o re direle,
work for us,
o re rerise, o re itshokele.
and whatsoever. Thank you.
Jaanong tsamayang ka kagišo
Can
lo
everybody-
bone Magauteng gore Northwest ke province e nngwe e mahura e nonneng.
Travel safely. I'm glad that you realize
Ko
that
ganyana kwa la
Northwest
re
is
ke
wealthy.
Gauta mara ga lona madi man.
In Gauteng, there's no money.
Ke a dumedisa bagolo.
Afternoon, elderly people,
O eme
everybody.
mo pele ga lona o ke Tsholofelo Molokwane.
My name is Tulufelo Molokwane.
Ke wa leloko la TAC.
I'm a TAC member
Mo ngaka modiri molema.
at Ngaka Modiri Molema district.
E ka re ga re simolola mo a ke re utlwile matona a bua.
When we started here, we heard our leaders speak.
Ba re gona le batho ba ne ba tsamaya mo ditleliniking tsa rona ba monitora gore medication wa rona go iragalang.
Explaining that there's people that monitor the facilities and checking if there's medicines and other services.
Ke ne ke le mongwe wa batho bao.
I was one of those people.
Ke berekile ditleliniki dingwe tsa ditleliniki mo ngaka modiri molema.
I have assisted to work in some of the clinics go at Ngaka Modiri Molema.
Ene mathata a ntse ke le reditse le bua ka one.
And most of the challenges that you are discussing here,
Ke a bone.
I've seen them personally.
Ke a itemogetse.
I accept that that is true.
Ke a itemogetse gore batho ba rona ba sokola mo di public health sector.
It is evident that our people are struggling at public healthcare services.
Ga ba tshwariwe sentle.
They are ill-treated.
Ba tsamaya ba kgona go ya ditleliniking ba boe go sena melemo e ba e kry-ileng.
They go to the clinic and come back without reaping any benefits from the trip to the facility.
Ba bang ba feleletsa ba defaultile
Others eventually default from their treatment
ka lebaka la maitshwaro.
because of the reception at the clinic from the facility staff.
Jaanong ga ke tle go nna motelela ke re filwe 3 minutes.
I will not be long. I only have 3 minutes.
Se ke batlang go se bua ke gore
What I would like to say is,
nna jaaka leloko la TAC
as a TAC member,
ke kgonne go bona lesedi.
I was able to see the light.
Ke kgonne go bona gore treatment action campaign e dirang.
I was able to see what Treatment Action Campaign does.
Le ga re ise re fitlhelele gore batlang go a teng.
Even if we have not yet reached the pinnacles we plan
mme
to
ke
reach,
kgona go bona light.
I am able to see the light.
And ga ke bue jana ka gore ke leloko la TAC.
I'm not just saying this as a member of
Ke
TAC.
bua yana ka gore nna ke a bona
I am saying this because
gore TAC e thusa batho ba rona.
I've seen that TAC assists our people.
And ke rata go leboga gore treatment action campaign e felleditse e fitlhile mo Northwest.
I would like to appreciate and thank Treatment Action Campaign for coming through to Northwest finally.
Forward we go TAC.
Forward we go. Amandla.
Thank you, comrades. Now we will go to the provincial department and the National Department of Health. I hope Comrade Buto, Umamu Grace, and other people who are supposed to respond are back online. But before I do that, in terms of protocol, it will be wrong for me not to give 2 minutes to the provincial chairperson of PLHIV sector in Northwest, Comrade Unewo Moepi, since he was here listening, and I trust that the leader has 1 or 2 things to say to us today. I know I ambushed him, but as a revolutionary, he is always ready to say something to the people. Comrade Newo Moepi, provincial chairperson of the PLHIV sector in Northwest, 2 minutes.
No, thanks very much. Amandla. Comrade Anele, I will not waste anybody's time by talking. I'm a trained soldier. I believe in warfare. So after listening to what has been said, it's very painful, but it also confirm and reaffirm what I've been raising with the provincial government as the chairperson of people living with HIV in the province, and as a person living with HIV myself since 1993 on my birthday, the 10th of October. So what I can just promise without playing to the gallery, you have spoken. Our work together with the collective is to go to the AIDS Council and go to the office of the Premier and every corner of the province and present your issues in a very military way, because our government and its system understand much better when you become very aggressive in dealing with them. They have dealt with our people in a manner in which it humanizes them, and we must take that insult and that type of attitude back to them. There's going to be an AIDS Council on the 30th, which I suspect it might not happen, because it is a decision that has been taken by government. They have never discussed that matter with us as leadership of the council from civil society to agree on the date, the venue, logistics, including the agenda. We will continue to fight and fight until to the bitter end. As I conclude, GS, I'm Kimurud. The Christian Bible says, be trustworthy until you even reach a point of death. That's what I can commit on behalf of the leadership collective. Thank you.
Thank you. Thank you. I will give to the leadership of the Northwest Department of Health. Now the time is 1:20. I think, to be fair, let's give them 6 minutes and give another 6 minutes to the Department of Health. I don't know whether it will be Ume Grace or Ume Puleng or Ume Judika, but the floor is yours. We are listening. Thank you. Northwest Department of Health.
I'm not representing department colleagues. We are just saying we have noted what the colleagues have raised, and we would appreciate that the recommendations that you came up with should be forwarded to us as the department, and we'll take this matter up with our principals. I thank you.
Thank you, Mayor. Is this Mayor Judika, ne? Judith, okay. Is there any other person from the Northwest Department of Health who wants to say something to us? We are listening.
The chairperson, good day, chairperson, and
Yeah, I think Ntate Moyepi, my name is Puleng Molefakgotla. I might not necessarily be in charge of most facilities. However, Judy has wrapped it up properly, including Ntate Moyepi. I don't have any further inputs. Concerns have been noted and all recommendations noted. I will help with Judy to take it forward to other colleagues at their level for them to be addressed. Thank you.
Thank you, Mepuleng. Now we're moving to the National Department of Health, but I'm told that there is no one available from the National Department of Health. As we are concluding, comrades, you know, we had a meeting like this in Gauteng. We had a meeting like this in Mpumalanga, and we have a meeting like this here in Northwest. I think moving forward now, because we cannot always continue to produce reports that are identifying problems, that are coming up with recommendations, and the officials from the Department of Health are not coming to the party. The Gauteng Department of Health, the Mpumalanga Department of Health, as well as Northwest Department of Health, they say they're gonna come back to us. So, I think as we are moving forward, I said in the beginning, we are no longer fighting with the department. We are engaging because we are partners and the clients of the department. But I think it is important now for us, as the leadership, to reach out to the MECs of health, to reach out to the Director General of Health, and report these officials of the department who make promises and not come back to us. Because all what we expect from the Department of Health, when they revert back to us, we issued a written report. We expect them, when they respond to us, they must respond in writing so that we can be able to track and follow up things they said they are going to do, what has been done, what has not been done. But it's evident that we still have a mountain to climb. And we are going to climb that mountain. And when we are on that other side, we will be able to see light. So I'm trying to say, comrades, there is no way in Gauteng, in Mpumalanga, and in Northwest, we're gonna issue other reports without us getting a feedback as to say, how are these problems going to be resolved? Monday, the national leadership of the PLHIV sector will be here in Northwest to prepare for the meeting with the Deputy President of South Africa, who is also the chairperson of the South African National AIDS Council. Unfortunately, I won't be able to be here, but Unewo, Mluleki Zazini, Spongile Chabalala, and Ukombe Tutemba will come here. I so wish that in that meeting, and also we need to meet with MEC Matoda Sambata. Fortunately, he's got the report I sent to him so that we can sit around the table with the MEC to see how us and the MEC we can work together to turn around the situation from the officials who are not taking irresponsibility. Without making State of the Nation address, comrades, on behalf of Ritshidze, on behalf of all the organizations that are involved in Ritshidze, I want to take this opportunity to thank you all for coming forward and sharing your stories. But also, comrades, it must not be about sharing stories. How do we in our communities, in our clinics, organize, mobilize other people who have similar challenges with us? Hold our facility managers accountable. Hold district health managers accountable, because without us, nobody is going to change the conditions and the situation we faced with. There is nothing about us without us, and we need to live that. So, in those few words, I thank you all, and our comrades, Rian and other comrades at the back who assisted us to do live streaming. I thank you all, comrades. I think on that one, Comrade Neo, as the provincial leadership in Northwest and Comrade Utemba, you are at liberty to do that on behalf of the PLHIV sector, so that, because comrades, one thing that I don't understand, at least before these virtual meetings, we will understand when people are not available for meetings. But now, you are attending a meeting in your comfort zone. But also, it must not be about attending to the meeting, listen and say, I'm not gonna say anything. If you are deployed by the department to come to us, we expect that somebody to make some commitments because you are being delegated. To come to us and say, I have yet, and we're gonna come back to you and not tell us how are you going to come back to us is actually undermining our intelligence. So, we are going to go back to Gauteng, Mpumalanga, and Northwest and demand that we get written responses from the MEC of Health, the HOD of the province. They must hold these officials they delegated to attend our meetings accountable, and at the end, we want to sit around the table with them, discuss as to say, how are these problems going to be resolved? On that note, may God bless all of us and reach safely to our destination. I thank you. Asante san. The meeting is closed.